उसको ठीक है, ठीक है। अच्छा वो है, पानी का है आपके पास? बोल, मैं ज़रा असल में खुद चेक करता हूँ तो। थैंक यू, थैंक यू। और मुझे वो दीजिएगा जल। लगा दिया? अच्छा ठीक है, आप उसको लाइट प्लीज़ ऑन कर दें। बस खैर आपने लगा दिया, थैंक यू। रेडी गाइस? ठीक है, तो आई जस्ट हैव अ क्विक लुक। उसके जो हैं, आप में से एनेस्थेटिस्ट कौन है? आप 10 साल? अच्छा ठीक। यार बस आपका मरीज़ है ये। अच्छा, जब खतरनाक है ना, परेशान है जब मरीज़, तो आपका है। वो मेरा एनेस्थेटिस्ट है, उसको मैं कहता हूँ यार थोड़ा और डीप करो, तो कहता है सर जिंदा है तो हिलेगा तो सही। ठीक है। और दूसरी बात, उसके भी बड़े वो हैं अकवाले ज़र्री। दूसरा कहता है सर नो जो है ना, इट्स अ कंप्लीट सेंटेंस। जो मैंने नहीं कर दी है तो बस बात ख़त्म। किधर है
Assalamu alaikum,
इमेजेस?
sir.
अच्छा ठीक है, हाँ ठीक है। तो
So
I'll just have
we
a
can
quick.
see you in the seminar.
Okay, yes. I just quickly just took the scope to we thought that we'll just have a quick look at the lesion, because I wasn't, to be honest, entirely convinced on the CT scan.
Okay.
So I just wanted to make sure that we can find the spot before we, start working on the, so,
Sure, sir.
and then I will give the scope back, and then so I'm just interrogating the pancreatic head area and just seeing if I can quickly.
आयशा रिकॉर्डिंग है।
Maybe this particular area that they are talking about, ये जो ऊपर है, इसके, so that's the portal vein, but यार ये थोड़ा सा करीब आ सकता है, या मैं दूर हूँ, या इसको ऊपर कर दें? इसको नहीं, इस ट्रॉली को थोड़ा ऊपर कर दें, बहुत दूर है। हाँ थैंक यू, ठीक है। नहीं नहीं बस ठीक है। हाँ नहीं नहीं, ये लग रहा है नॉर्मल लग रहा है। हाँ लेकिन मैं ये देख रहा हूँ कि ये बाइल डक्ट मैं देखना चाह रहा था कि मुझे नज़र आ जाए। मुझे लगता है इसी का जिक्र कर रहे हैं लोग उस पे स्कैन पे ना। हाँ वो लुक्स लाइक मोर लाइक अ नोड आउटसाइड, वो जो मैस जिसका जिक्र कर रहे हैं वो तो इधर मुझे नहीं मिल रहा। So I'm just interrogating the head of the pancreas just to see. So you see, this is the tissue of the head, na? So this looks as if there isn't anything there, but वो जो एरिया जो आप कह रहे हैं ना, वो नोड है लग रहा है मुझे। आई थिंक इट्स लाइक अ चंकी नोड्स है ना। हाँ ये वाला ना नोड है, बट इट लुक्स, हाँ हाँ इट लुक्स लाइक अभी इसके साथ ही पड़ा हुआ है। And this node as well, there is a node there. So I'm just trying to see if we can. स्लिप हो गया। So Novel, is the team there yet, or we're still waiting?
They're on their way, Dr. Shah.
They're on their way. Okay,
Yeah.
I think what we will do is that, just in the interest of time, I am going to biopsy this to start off with, and then we will, start the teaching. Is that okay? Is that
Yeah,
better?
that's fine. I think that
Yeah,
sounds good.
because you see, the pancreatic head to me looks fine, but there's a lymph node here, which I would like to biopsy, this bit. Can you see that there?
Yeah,
guys?
yeah, we can
So
make that
we'll just
out.
quickly see if we can biopsy that bit, and then,
22
yeah, 22 FNB. ठीक है ना डॉक्टर सादिक, we'll just take a quick sample from that bit.
साइज करेंगे
हाँ जी, एक मिनट ठहरिएगा, अभी नहीं, हाँ मैं आपको बताता हूँ, आप कर दें, हाँ ठीक है, हाँ मेजर कर दीजिएगा प्लीज.
ठीक है सर
हाँ
ओके साइज 10.8
कितना?
10.8
10.8 बस ठीक है. I think this may be the area that they were probably trying to mention. हाँ जी, पिक्चर ले लें, पिक्चर ले लें.
Dr. Shahzad, where exactly is this lymph node in
So
relation to the pancreas?
it's just in the so this is the portal vein, if you see in the bottom. So it's just above the head area. Can you see that? That's the portal vein.
Yeah.
So I'm not very good with this cursor. Yeah. So that's the portal vein. You know, superior mesenteric vein, splenic vein, head of the pancreas, and there's a just node above it here. So we'll just, this seems to be the most prominent thing there. We'll take a quick biopsy from this area.
Right.
Doppler लगाइए. So a lot of vessels there, but they are small, so hopefully we should be okay from that perspective. ठीक है जी, ऑफ कर दें डॉक्टर. एक मिनट चल निकाल.
सेक्शन अब चाहिए
हाँ प्लीज ले लो. हाँ नहीं, एक मिनट, आपकी बात सही है. कम एक मिनट हट डॉक्टर सादिक ने अच्छा पॉइंट उठाया दिया लिम्फ नोड. हाँ, लेकिन वो यूजली ना लिम्फोमा वाले लिम्फ नोड्स होते हैं, जो मिलिग्नेंट लिम्फ नोड्स होते हैं ना. हाँ हाँ, वो जो लिम्फोमा वाले होते हैं ना, जो ऊपर होते हैं आपके मेडिस्टाइनम में, उस पर मैं आई एम अ बिट मोर वेरी. हाउएवर द रेस्ट ऑफ द टीम, खालिद भाई एंड डॉक्टर साद हैव मेंशन्ड अ पॉइंट that it is better to start off by not doing suction if you can get solid tissue rather than. I think one of the differences, if you do cytology, you are more against suction because you want to see cells, whereas if you're doing cores, you know, if you're doing mows that we tend to do, then you're okay with a bit of blood because you actually want the solid tissue. So while they're getting that, again, the CBD doesn't look to be dilated, and this bit is not very obvious. Yeah. So that's the portal vein. The CBD should be above this.
Dr. Shahzad?
Yeah.
So we were just wondering, on the basis of EUS, do you think it's a malignant or a benign one?
So the lesion that was mentioned in the head of the pancreas, I haven't been able to demonstrate that bit. So this obvious lymph node was there, which looks actually a bit suspicious. If you see, it looks rounded, hypoechoic, clear margins. So it is not entirely innocent, this lymph node. And that's why we have decided to biopsy it. And it's sizable, so it's at least 1 centimeter in size. It's hypoechoic, it's got clear margins, it's rounded, it's in the area of interest, so all of those things do go against this particular lymph node. Whether it's malignant or not, obviously the biopsy will tell us, but it does look suspicious to me, this particular lymph node.
You're right.
Once I've taken the biopsy, I will try to interrogate the area of the pancreas again, because I want to make sure that we're not missing anything. But as far as I can see, and I'm sure you guys can see it from there as well, the head looks clean actually. There doesn't seem to be any obvious mass except for this lymph node that is coming up there. There's one here, and you can see there's another one coming up here. Can you see that lymph node up there? जी कुछ आया? There's no sample on it? Okay, we'll take another. So we'll do suction this time, yeah. हाँ कर लें, मुझे लगता है हाँ, पता नहीं, मुझे ज़रा तसल्ली ज़्यादा होती है। खैर आप लोगों की अपनी ये नीडल आपने संभाल के रखी है, क्योंकि हम ऊपर से अभी हमने एग्जामिन नहीं शुरू किया, डॉक्टर साहब करेंगे ऊपर से एग्जामिन, तो वी जस्ट डिसाइडेड टू हैव अ लुक बिफोर दैट बिट।
बेहतर है सर आप सैंपल अगर पहले ले लें।
असल में वो थोड़ा सा ये केस उस तरह। थैंक यू, थैंक यू। जी सॉरी, हाँ हाँ बिल्कुल। नहीं सीटी में भी हो सकता है, हो सकता है। आपका मतलब डेवलपमेंटल है ना, जो डेवलपमेंटल होता है। डॉपलर लगाइएगा थोड़ा सा। दैट्स फाइन, यू कैन क्लोज। हाँ तो मतलब ऐसा हो सकता है। हाँ चलें जी, निकालिएगा प्लीज़ और सक्शन लगा दीजिएगा। So there were some small blood vessels there, but they are not much to worry about. You do have blood going through the lymph node as well. So it is 1 centimeter, 1.1 centimeter hai. So that's why it is important that we take. Yes, please. Yes. So although it is soft, I must say, it is not hard. Like a particular tumor lymph node. So it's 50-50. Better to take sample it. And then there's another lymph node just around there. We'll take another sample of that and we'll assess that sample as well. So I try to go right to the edge and then go right to the edge again from the other side so that you can get samples from there. So a little bit of blood there because of the suction, but nothing much to worry about, yeah? Yeah. We'll just biopsy that lymph node as well. We can put both in the same pot. Don't need a separate pot for them. But just let us know when we get some samples, and then अगर नीडल फारिग हो गई है तो वो दे दें मुझे, ठीक है, हाँ ले लें। So that's the portal vein again, and yes, that's the portal vein. We've got the SMV, the head of the pancreas, and splenic vein coming. But again, I can't see any Did you get any samples?
जी इसमें देख
A
रहे हैं
bit.
सर
Okay, that's fine. So this is a particular lymph node that other one that I'm interested in. We'll just size it first. Can you size it, please?
Okay,
Just pause
size,
it and
okay.
size it, yeah. Yeah, and then just size it again. Yeah. So it's probably 1.2 or something like that. How much is it?
This looks bigger than the previous one.
Yes. So it's 13.6, and it's more rounded as well. It is close to the same area. We'll take a picture of it if you can. Yeah, thank you. So we'll just sample it. We don't need to change the pot. We can put it in the same pot because it's from the same area, same region of lymph nodes. So I tend to move the needle slightly out again, the sheath of it, so that it doesn't damage the scope. And once I can see it in the echo endoscope, I just pull it back so that I don't damage the tissue. हाँ क्या है उसमें कुछ पता लगा? हाँ देखें ठीक है tissue. So we got some tissue. We'll see if we can identify what it is. And while we're doing that, we will sample this bit. Doppler, please. So there is a blood vessel up there. Let's see where we are needle-wise. Yeah, we should be okay. You can switch off the Doppler. Yeah, that's okay. Just see, let's see what comes up on it. So there is a small blood vessel in the middle, but I think we should be okay. Yeah, okay. Just give me a second. Let me just, it seems to be a bit rubbery. So you can see we're close to the other blood vessel. However, in my experience, we can usually push it a bit safely without causing, so we are in now, yeah, okay. Suction now. So I'm going to make sure that, yeah, we seem to be in there. Yeah, we'll see if we can get some samples from there, yeah. So although we are pretty close to the blood vessel, when we push it, it pushes the blood vessel away as well. So we should be okay, yeah.
Suction on?
Yeah.
Yes, please.
So excellent, that's fine. Let's see if we can get some sample from that one. Oops, sorry. Here's the note.
Yeah.
Yeah, sorry. Okay, so while we're just looking at that, I'm just going to interrogate this area again. So now we can see those two lymph nodes that we have identified. The larger one was 1.3 centimeters. That's the pancreatic head up there. The bile duct is not very visible here, which in some ways suggests that it is not dilated as well. It's probably coming up right on the top area.
The duodenum and the periampullary area are perfectly right?
Yeah.
Okay.
So we're just going down to the head. A bit, yeah. So that's all the head area. So we've got good views of the head of the pancreas. We're getting very good views of the head of the pancreas. So okay, freeze, unfreeze कीजिएगा endoscopy के लिए. Unfreeze करो. Okay, sorry. Okay, so we'll just see if we can now just ease into the duodenum area and then, okay, वापस ले EUS वाली images ले. Okay, excellent. So that's the आया कुछ उसमें
सैंपल सर्विस में आया है
आ गया
जी
ठीक है but what is it हाँ
स्लाइड
लग रहा है malignant so we seem to have got the sample from that lymph node and Wasim is telling me that it looks as if it's malignant cells. Again, you know, the scope slipped in, but I couldn't see anything in the Uncinate process. So I'm going to give the scope now to Dr. Sadiq. I'll just remove it so that he can intubate it as well. Yeah. Okay. No, it's okay. The intubation bit is important. So while I just have a quick look at the sample. हाँ जी, वसीम कुछ हाँ लेकिन वो उधर malignant
सारे सेल्स एबनॉर्मल सेल्स
सेल लग रहे हैं
enlarge overlap or different shapes different size
okay so it looks as if we've got a bunch of abnormal cells on the lymph node so we should be okay so have you intubated yeah excellent
So Dr. Shazad, you didn't find anything in the head of the pancreas?
No, I didn't actually. So we didn't find anything in the head of the pancreas. However, there were two large lymph nodes there. One was 10 millimeter, the other was 13 millimeter. They looked a bit suspicious. We have taken some biopsies, and I've been told that the cells, we've got good samples, and the cells look abnormal in it. So we should be able to get our answer from that. But while we are in, we are going to assess the pancreatic body and tail, and then we can move back to the head when rest of the team are there as well. So you've got the scope at the GOJ? Yeah. At which level are you at? I think you're slightly further down, isn't it? Just pull back slightly, see if you can be at the GOJ. Just endoscopically, yeah. Yeah, that looks like the stomach. Yeah, just slightly above, slightly above. I think you're still a couple of centimeters down. Go up, go up, go up. That's it, stop there. You can see the edge now. Now at that point you should be facing the liver when you enter the scope because your tip is tilted towards the left side. So if you suck all the air in, yeah, and you can put the other finger here, yeah, and just to avoid, and yeah, that's the a good image of the aorta. So what you want to get is a good image of the aorta. So now the aorta is becoming a bit more horizontal, which means that you're too far out. So you can push the scope in. You can see the first vessel that's coming off is the sorry, I can't move that cursor. Yeah, okay. So that's the celiac axis, you know, and below it is the SMA. And this is the aorta. Okay, so you're getting good images. So your scope, your aorta is still coming a bit more horizontal. We would like it to come a bit from here down to this side. So to do that, you just need to push the scope in a bit. Yeah, excellent. Yeah, that's great. That's great. Just suck all the air out. Excellent. So you're getting good images of it. Excellent. So just let's pull the scope slightly back and see if we can, yeah. Use the little wheel to see if we can change the orientation of the aorta a bit. Just very gentle movements. Yeah. Excellent. That's great. Excellent. Okay, now go to the liver. So do a clockwise rotation. Go to the liver, and then you can come back all the way to this bit. Yeah. Excellent. The images are not coming up very well. I'm not sure how I can improve those in this. That's slightly better. Okay. Now move all the way around towards the aorta. Try to find the aorta again. So there seems to be some lymph nodes up there as well, isn't it? Can you see those? Yes, you can see some lymph nodes above the celiac axis.
Yes, Dr. Shazad, we are.
Oh, excellent.
We are seeing there are many lymph nodes around.
Excellent. So this case, there's a patient, a young patient who's come in with tummy pain. I think you've heard the case. There is a 1 centimeter hypoechoic suspected area in the head of the pancreas and some peripancreatic lymph nodes. We went quickly in to start off with, and we found some lymph nodes, a couple of them, 1 centimeter and 1.3 centimeter. We have sampled them, and apparently there are some abnormal cells in there, which Wasim has mentioned. I will ask Wasim to put them on the screen if they can, for you guys to see as well. So, and then we've moved on to some teaching.
Can please pancreatic parenchyma at the left?
So if you just pull back slightly and then do a clockwise torque. So yeah, so we are now in the body of the pancreas. You can see the left kidney down there. That's the splenic vein. Okay, at this level, just try to follow the splenic vein right to the hilum. So if you continue doing a clockwise movement, you should be able to see the splenic vein go into this hilum. So that's very, you're in the hilum now. So that's very good. So you can now follow it backwards towards the neck and the body. So there's the left kidney coming into view again, and you've got the splenic artery just above. So you just push the scope in slightly. You seem to be coming out. So just push the scope in slightly. Okay, just try to get the splenic vein right at the 6 o'clock position here, down here. Yeah, excellent. So that's the confluence. Excellent, good views of the confluence. So this is the portal vein. That was the splenic vein going up. So portal vein, splenic vein, and you've got the SMV coming up here. That's probably the IMV. If you see that, that's the IMV probably. And if you just keep on going, yeah, go back, up and down, yeah, excellent. So probably that's the left gastric that's coming off, this one. Okay. So that's the genu area, and then the body. So you can go back towards the hilum again. So clockwise torque from there. Just try to find the splenic vein. Yeah, that's the one on the top. And you pull the back scope slightly backwards, and then keep on doing a clockwise torque. So when you're going towards the tail, you usually need to pull the scope slightly back because of the tilt of the pancreas. Yeah, excellent. You're getting good views of the pancreatic body. Excellent. So keep on going. Just pull the scope back. You see it seems to be vanishing, the splenic vein. Try to get it at 6 o'clock position if you can. So if you're just going beyond the left kidney. You're entering the tail of the, you're in the tail of the pancreas now. Excellent. So you're just following the splenic vein all the way to the hilum. Okay, are you comfortable with this station? Yeah. Okay, let's go to D1 now. So let's just interrogate the head of the pancreas. Actually, before we do that, there were some lymph nodes that we saw up here, isn't it? So should we see those, the celiac axis? Let's just try to get to the celiac axis again. So if you find the aorta again first. So go back, pull the scope back slightly. You need to be at the GOJ, yeah. Keep on pulling back the scope, yeah, and do a clockwise torque, and you should be able to be on the aorta. Yeah, the aorta was coming in. Yeah, you can see it here. Yeah, you can see those lymph nodes up there. Yeah, do a bit of a clockwise torque, and you should be able to see some. Clockwise torque again. Yeah, there's one lymph node coming up there on the, yeah. Wasim? So can we project the slide, please, as well? Just project on the on the screen. Let's just see. Let's see what you guys think about the cells that we've got. Okay, so just pull back slightly. We just need to find the aorta again. So yeah, so let's see if we can. So at what level are we? Yeah, just suck all there. There's a lot of air that's coming in there, yeah? Okay. That's the aorta, yeah. So what do you guys think about the slide, the cells? Can you hear us?
Yeah, we can.
Okay.
So, ये स्लाइड को ज़रा और फोकस कर देंगे कौन है वहाँ पे बैठा हुआ वसीम तुम्हारी आंखें बूढ़ी हो गई हैं।
आप देख लो सब थोड़ा।
हाँ।
नहीं खैर आप D1 पे जाएं, you can go to D1 now. वो छोटे हैं lymph nodes. Celiac में lymph nodes they are not that significant, so you can go to. So I think their Wasim is there. They're asking for focusing the slides a
ये
bit
तो
more.
सारे RBCs हैं,
Okay.
कोई atypical नहीं है, there's a lot of crush artifact ना, तो यहाँ पे कुछ cells हैं, तो they look like a lymphocytes but they
So we are just.
it's not a crush artifact.
I think that's the bile duct. Let's have a look at the.
lot of staining. Crush करने को बहुत लोग crush कर सकते हैं, और लोगों में बड़ी जान होती है, सब कुछ crush हो जाता है। RBCs are not crushed, हाँ, लेकिन ये है कि कोई भी regular cells भी जो है ना crush कर सकते हैं, it's not hard to ये duodenum जो है ये normal है या हमें सही तरह नजर नहीं आ रहा endoscopic view?
No, it looked a bit slightly inflamed, but part of it is because of the scope as well.
Okay.
So there has been some scope trauma, I think, but it looked a bit inflamed. Yes, and we did a biopsy as well, so there's a bit of blood because of that.
Operator effect. वसीम कोई और स्लाइड है?
So you can see the lymph node up there, that's coming up.
Yes, we do.
So that's the sample that we've taken from that lymph node.
The lymph node, looking at it, looks really benign.
It does. In one of the areas, it was 1.3 centimeters, looked quite rounded and hyperechoic. Although when we put the needle in, it was very soft.
So if you look at the lymph node, there is a white area in the lymph node. So either that's a fibrous band. मैंने पहले नहीं देखा. I don't know if it was like that. Yeah, that's what I was coming. So if it was like a more homogeneous before, and then you see it, then it's a bleeding. और अगर EUS में the clotted, like अगर blood, if you look at the blood in the aorta,
Okay, so get the
it's just
portal vein.
all
Get the
anechoic.
portal vein again.
But the clotted
So
blood
get the portal
looks
vein.
hyperechoic. So flowing blood is anechoic, clotted blood is hyperechoic.
So I'll just quickly have a look at this area again. So this was the bit. So this is where we took the biopsy from, Dr. Khalid. This lymph node here. Just let's pause it. Where is the pause thing? Yeah. So it was 1.3 centimeters, looked a bit more hypoechoic. I think because of the needle, it's becoming a bit mixed texture as well, a bit. So what's your comment on this lymph node? Can you hear us, guys?
Yes, we can. Sorry, you were talking. What's the
Okay.
question?
So this lymph node, just a bit of a comment on this particular lymph node.
So this is like it has a very like a well demarcated, even though irregular boundaries, but there is a white band in the center. So that usually points towards a benign etiology. So if it was a very regular, round, all black lymph node, that would be more problematic as compared to a large, triangular, irregular, and mixed echogenicity lymph node. So this, to me, looking at by EUS features, it looks benign lymph node.
Okay, so this is the second one we have sampled, this lymph node here and this lymph node here. So those are the two lymph nodes that we have found. So looking at the pancreatic head, according to the CT scan, there was a suspicion of a 1 centimeter hypoechoic lesion in the head of the pancreas. We interrogated it, but to us the pancreatic head looked quite unremarkable actually. We weren't able to find any lesion there. The ducts were not dilated.
can you keep going to the clockwise, gently, clockwise,
Yeah.
slowly, slowly, right where the, yeah, further, further, by pulling it back. I think it's just a little bit shadowed. It's right where the duodenal wall was, but I don't see anything. I agree with
Yeah,
you. Yeah.
seems quite. So we've slipped back, yeah. Interestingly, the patient's bilirubin is 4 and the ducts are not dilated.
The liver looks okay. When you look at the liver, the one which is a white band, that usually is a portal system. The other one with the black, like no walls, that's a hepatic system.
The ducts are not dilated in the liver. That's the portal vein, splenic vein, SMV, junction confluence, head of the pancreas on the top. The pancreatic echo texture looks fine. That's the lymph node that we just sampled. We haven't been able to identify any lesions here. I just was wondering if it will be better for us to request the CT for, the CDs for that CT, and just to review those, because I'm not entirely convinced that there is a mass there in the head of the pancreas.
And that bile duct looks completely normal.
Yeah, so, and it's not dilated, although the bilirubin is raised, so.
So, what about the rest of the LFTs? They are high too? Liver test? AST, ALT, alkaline phosphatase?
So we can put the slide up of the patient's history if you wish. I think Dr. Novel has it. You want to have a go? Yeah, just इस जगह को थोड़ा interrogate कर लें आप अपने history के लिए. So that's very good views of the portal vein you're getting. Yeah, excellent. So that's the head of the pancreas. Yeah. हाँ, आप देखें इसको किसी भी चीज़ को अगर आपने इस तरफ करना है ना तो आपको स्कोप को पुल बैक करना पड़ेगा, और उधर करना है तो अब आप इसको, हाँ, थोड़ा सा दूर खड़े होंगे ना तो आपको इसको एबिलिटी इसको मूव करने की ज़्यादा हो जाएगी. हाँ, एक्सेलेंट. थोड़ा एंटी क्लॉकवाइज दें टॉर्क. आई थिंक यू शुड बी एबल टू. बाहर निकल. हाँ, ठीक है, अंदर चले जाएं दोबारा वहाँ से. That's good. So you got that view. So now clockwise torque. So that's where you are touching the confluence area. That's the head of the pancreas. Now follow this further, the SMV, and you should be able to continue to see the rest of the head of the pancreas. Excellent. Yeah, that's good views that you're getting. Yeah. So we're deciding to call it a day. We'll get the films, the CD, to be reviewed again, and we'll just see what the samples come up with. Biopsy, huh? I think they can't hear us, yes? Okay, they're setting the slides, yeah. I think you're quite deep in now, yeah, but that's okay, yeah. Yeah, it's probably the segment 6 now.
So, Shahzad, thank you. We're going to go to the other room.
Okay, thank you very much.
Thank
you.
Can we go to the other room?
Just is find a place where you're stable. We kept pulling back. So you don't want to pull back. Liver, you like this. And just that.
Mustafa, can you hear us?
Yes.
We are with you now.
Okay, did you hear about the case?
No, we did not. We're going to talk about case for just for 30 seconds and then we'll be with you.
Okay, so try that. Big wheel towards you a bit. Good, keep going. You see that? in like only about 90 degrees, you went all the way from liver all the way across to spleen. So now go back the other way and slow down a bit. Go back, keep coming down, go back to liver. Keep coming down, keep coming down. That's it, keep coming down. Big wheel towards you. You see the liver? There you go, there's your liver. Okay, good. Keep coming down. We're going to start all over from the liver. So you just keep coming down, it's okay. Now I want you to go back to the aorta. You can go faster, it's okay. It's easier to go faster, but just to see, this elbow is getting bent again. So thoda sa bas relax karke. And ultrasound में the other thing that's important is to have freedom of movement, the bed needs to be lower. ताकि आपको अपना shoulder ऊपर ना करना पड़े. Now the bed is lower, so it's easier for you to move around. And there you go. See that?
Yeah.
So aorta. Now go back to liver. I want you to do this one more time. Go back to liver. Okay, good. There's your liver. Big wheel slightly towards you. Good. Now go clockwise. Keep going clockwise. I want you guys to look at the arm movement here. So not a lot of arm movement, but a lot of scope movement, suggesting that there's freedom of movement. And he just scanned all the way from the liver to the celiac and aorta area. And now he's showing off that he can even get to the spleen. So that's excellent. So now let's go back to this. Okay, now we're going to stop at the celiac. Show me the celiac again.
Okay.
No, you do it. Good. And now you're going to, so go slight. That's, okay, just for recognition purposes, aorta, crust of diaphragm. So now go, there you go. Show me the celiac again, right there. So go ahead and identify the celiac one more time. Go the other way, maybe. There. So that's your celiac. Now gently relax your big wheel and advance your scope. So you're following the celiac, branching into the splenic and common hepatic. So relax the big wheel and keep advancing the scope. There you go. And as you do that, that's the left gastric coming off, and there's your pancreatic duct. So keep advancing till you're on, your probe is on top of this duct. Right now it's in front of you. So you have to relax your big wheel, that's it, and keep advancing your scope. Keep advancing, till you go drop on top of this. Keep going. There we go. Now you're on top, right? So again, you want to have the duct below you, and now you want to maintain that position. So keep advancing because you're going to drop back. So keep advancing a bit. Relax your big wheel. There. Now you're going to maintain a bit of big wheel. So it's falling back. You have to maintain that position. So move forward. There. Now you're going to maintain this position and go clockwise towards the tail of the pancreas. But you see it's dropping. So you have to push forward. It's okay. Advance your probe. Keep advancing. Good. Keep advancing. Relax your big wheel a bit. It's better to have at this stage, because you keep dropping, it's better to have the probe to the left of the pancreas here. So bring the duct down here for a minute. So advance. There you go. Keep advancing. Okay. A bit more. Okay. Now what you're going to do is, now don't push more. Maintain this position with your big wheel slightly towards you and go clockwise. See, as you now maintain it that way, the duct is slightly, so now, okay, slow down, go back the other way. Now the duct, because it's going to the right, you're going to pull back a tiny bit. So go clockwise. And as the duct starts falling to the right, you have to pull back your scope a tiny bit. But you can't do it ahead of time, otherwise you'd slip off. So you have to go forward again and go clockwise. If this is too low, I can raise it up. Okay, now keep going clockwise. The back should be straight, otherwise you're going to end up with a bad back. Good. Now pull back a tiny bit because the duct has gone off to the side.
Okay, sir.
There you go. So keep pulling and now going clockwise. And usually it's going upwards. So that's good. That's your pancreas. You're going to pull back and big wheel towards you a bit to follow that pancreas. There you go. Now if you're losing it, you have to go the opposite direction. Good. Now pull back a tiny bit more and go clockwise. There's your duct. So continue to keep an eye on this area. So, so you have to figure out big wheel towards you or more clockwise. I think you have to go more clockwise. There you go. Keep going more clockwise. Keep going clockwise. Keep going. Keep going. Keep going. Now the spleen is starting to come into view and the pancreas is to the left here. So you have to push forward a bit. Relax your big wheel and push forward a bit. And keep going clockwise. And sooner or later here you lose your pancreas, but keep going clockwise for a minute. That's your spleen. If you have the spleen, stay here and go counter.
Okay, sir.
Big wheel towards you a bit.
Towards me, sir.
Good. Go counter. Keep going counter. There's your pancreas again. So you can retrace it. And if you want, just keep going clockwise. There we go. Okay, good. And now pull back a tiny bit. So you just want to do everything you can to see, because sometimes you'll have a lesion in the very tail of the pancreas.
Okay, sir.
And if you miss that, then it's not good, right? So keep going clockwise, big wheel towards you and clockwise till you try and see the end of this pancreas. It's probably somewhere there. You may have to push in a bit and go clockwise here. There you go. Keep going, keep going, keep going, keep going, keep going. And I think you do lose the pancreas there. So keep going. It's okay. Keep going to the end. Keep going. Good. Okay? You happy with that?
Yes, sir.
Okay, now show me the celiac again. Okay, so good. That's just splenic artery. If in doubt, the easiest way to get to celiac is come slightly back to G junction, get to your liver, and find your celiac again. So make sure you look endoscopically, because if you pull back without looking, you may end up in the esophagus and then you're struggling to find it. So look endoscopically. Good, right there. Push forward a bit. Good. Big wheel towards you now. And go clockwise. Okay, that's your aorta. So relax, yeah, advance. Relax your big wheel a bit. And try and look, where's our, we're already off the celiac because you already have pancreas. That's okay, just find me the PD. So again, you're gonna, to get to the PD, you're gonna relax your big wheel. Push forward, keep relaxing, till it's, yes, that's it. Now you're going to go counterclockwise towards the neck of the pancreas. So you have to, that's it, keep going, that's it. And it's going to fall away from you, so you may have to do big wheel towards you. Keep going counterclockwise, and it's dropping there this way, so big wheel towards you more. Suction, or big wheel towards you, suction. Okay, let me show you this part. But that was good. So basically you find as any time your pancreas is to the left, you have to push forward. Now I'm trying to keep the duct behind me because it wants to get away from me. So I'm doing a bit more big wheel towards me as I go counter to try and maintain that view of the duct. For me, the duct is what I want to follow. So there. So there's the duct. I was going clockwise. So this is clockwise. Now I find my duct counter. What vessel is this? It's okay. Is it an artery or a vein?
Vein, sir.
How do you know?
Sir, flow.
Okay, that's good. What else? What other ways are there to know? How else can you find out if it's an artery or vein?
Sir, artery prominent होगी, ठीक है sir.
So ये क्या है? Is this, what is this one?
Seems to be the vein, sir.
So दोनों
artery,
veins?
artery,
Why is
ये
this?
artery.
ये क्यों? Why is this an
Sir,
artery?
filtral नहीं है sir.
अच्छा,
Compress. तो ये
अच्छा,
flow आ रहा है backup से. ये
ठीक
तो
है. So
that is
flow
one way.
pattern is one way.
Yes.
दूसरा ये कि the wall may be a bit more
Vein,
prominent. And तीसरा ये कि you have a tool for this, right? You just go to your flow, right? इन दोनों पे हम flow check कर सकते हैं, and then you can look at the waveform. You can be 100% certain venous waveform, and then this is an arterial waveform. Again, if I can get it into view. Let me see here. I can't prove it right now, but that's another way to do it. I think I'm just not getting as good a view. Let me try this view. Unless it's the bile duct.
That's a
Actually, that's a
bile
bile duct. I got
That's a bile
confused.
duct.
Yeah, sorry. So that, again, I got confused, but if it's not making sense, then it makes sense. The reason I got confused was because this is actually portal vein, SMV, and then usually behind the SMV is your SMA. So I was looking for this vessel.
Yeah.
That should be
And
the
that's your
SMA.
SMA. So I just had to go in more. So it goes to show that if your preconceived idea is, if you have something, this is what I think it is, you can make a mistake. I was thinking it's an artery, so I was trying to prove it's an artery, but actually it was a bile duct. So that's why it's important to recheck yourself. And then if it's not making sense, you have to say, okay, well, what else could it be? So here's our SMA, SMV, and that was the confluence. And actually that was the bile duct, which I thought was the, so this is your SMV, slightly clockwise is SMA, and if you keep following it back, you can actually see it to the aorta right there.
Again.
Yeah. And then this structure here is the dilated duct that they have already told us about.
Bile.
And secondly, this is your pancreatic duct. This is your CBD, and we're just going to follow it. If I keep going big wheel towards me and keep pushing in and go clockwise, we may even be able to see it almost all the way to the papilla, right? There, we lose the bile duct here, but you can see the PD going almost to the papilla, and there's your bile duct. And because the bile duct's not really compressed here, this is a good way, a good place to measure the bile duct. So I don't want to take away your time, but I want you to do this quickly. So the bile duct here measures about 10.5, okay? So I don't know, we're capturing images or not? Okay, okay, good. So go ahead and what I want you to do is, I'm going to give it to you on the PD, okay? There's the pancreatic duct. Again, this is your SMV, confluence, splenic vein, portal vein, okay? That's your confluence. So I'm going to give it to you with the pancreatic duct here, and what I want you to do is slide big wheel towards you and go counter. It's counter and then clockwise. It's like two different movements to follow that duct, okay? So you take over. Yeah. Good. So now you saw you lost it. So you have to maintain the view. Now if to follow it, you have to go clockwise. So go clockwise, and now the PD is going down that way.
Okay, sir.
Bile duct, PD, and if you go, there you go. That's the neck area. Now if you go clockwise from here, you'll follow it towards the tail. Just to prove it. Okay, keep going, keep going. Okay, I don't want to waste time. Now stop here and go the other way and follow that pancreatic duct. And you'll see you have to go counter and then clockwise to follow the duct. But towards the head. Go counter, get it past the vein. Now big wheel towards you and go clockwise. And now the duct is below here. Do you follow? Okay, good. Let's go to the bulb. Again, and then that was the bile duct.
Okay, sir. Dilated.
What structure is this? This one. I'm testing you. Vein or artery?
Vein.
Okay, good. Which one? Go counter.
Okay.
This vein meets
portal.
this. Okay, so which one is this? This is
Portal.
this is
vein.
portal. Good. This is what? Go clockwise. This is what? Goes down.
Spleen.
Goes down towards the feet.
Superior mesenteric.
Good. And what is this one that goes up, back up? There you go. There's only three we have to remember in the pancreas, right? And the which artery is this?
Artery. Superior mesenteric.
No, it's not. Remember we were thinking it's artery. That was a trick question. I like you, that's why I'm tricking you. This is the bile duct.
Okay.
All right. Okay, go to the bulb. You know, when you're doing procedures, you look very serious on the camera. I want you to smile. That's why we're doing this. Okay, go towards the pylorus. I think Dr. Ghaz Saab makes you very serious when he's teaching you. And I want you to be smiling. Okay, good. So now good. You're almost in the bulb. So push forward. Copy. Good. Keep going in. You have to go into the bulb. You just kissed it and came out. You have to go inside. Okay, go. Smaller to the left. There you go. Push. There we go. Now you're inside. Now go count. Now you have to try and figure out where is my biolic. Because right now in ultrasound we don't see anything. Usually in this position you have to go counterclockwise. And if that's not working, go slightly clockwise. There you go. Okay, when you went clockwise, you found your what is this? That is good. What else? What is this? What is this structure? Good. What is this? What's that?
PD.
Good. Just confident. I just want confident answers.
Okay.
Even if you're wrong, be confident. What is this?
PD again.
Well, that was PD. Why is it so different? Let's put Doppler on first, right? Is it a vessel or a duct?
Duct.
Good. So if it's not PD, what else could it be?
CBD.
Good, right?
CBD.
And there you go. And you have the cystic here too. So now that you have the duct in view, what is going on here is the bile duct and the cystic duct are merging. And just this is like nature helping you unintentionally with your movement. You just went from the merger down towards the papilla. Now keep that big wheel towards you. This is perfect, right? See, the minute you touched it, you changed it. But this is good. Now go counterclockwise towards the liver. You're going to follow this bile duct up. Okay, now it's separating cystic and bile duct. Relax your big wheel because it's to your right. Relax the big wheel, push forward, good, suction. All those things have to happen together. And keep going counter. Keep going counter. Relax your big wheel. Relax your big wheel. Relax, 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 relax. Relax the big wheel. Keep relaxing it. You're compressing it. Keep relaxing it.
Relaxing.
There you go. What do you see in there? What's that in the duct? Why
It's
is
a duct or a gallbladder remnant.
We'll figure that out. Is it stent, stone? What is it? But that's a good point, Dr. Hassan. What is it? Big wheel towards you? Why is it a stone or a stent?
So whitish structure.
Okay,
So
so
these
we
no
have whitish is
development.
not a EUS terminology, right? Is it
Hyper.
hyper what?
Hyperlucent.
No, it's not lucency.
Hyperdense.
No, it's not density either.
Hyper intense.
It's not hyper intense.
Density.
Yeah, I'm testing him, guys. So echo, right? In ultrasound, there's an echo, there's a shadow. Hyper-echoic. And what else? Show it to me again. Go clockwise. Go the other way. Wherever you can find it. Keep going the other way. If you go this way, then just keep going, right? What else? It's hyper-echoic, and then what else do you see behind it? You see these? What's going on here? There's a shadow.
Okay, stone.
So hyperechoic shadowing structure, and for your report you can measure it, right? We say it measures about 9 millimeters, 8.5 millimeters. So it's a hyperechoic shadowing. What else? What do you call that? Stone, right? So it's a hyperechoic shadowing filling defect consistent with a stone. That's how you want to report this. And then Dr. Khalidson said, is this the gallbladder remnant or is this the bile duct? For that we have to study the structures, both the bile duct and what may be the gallbladder remnant. So you have to spin around, go counter. Keep going counter, keep going, keep going, keep going. Relax your big wheel. Relax that big wheel. There you go. Relax, good, relax, good. Keep going counter, keep going counter, keep going counter. Okay, you're losing it, so relax your big wheel. Push your scope forward a bit. Good. That's good. Now go counter. You're going clockwise. So push your scope forward. There. Relax your big wheel. Relax it. Your big wheel is not getting relaxed. There we go. Keep going. Keep going. Keep going. There is your separation of the two structures. Keep going. You have to keep dropping your left hand like this. Let me take over just first to evaluate if this is bile duct or
Yeah,
gallbladder.
I think it's a little bit not clear. It's a bile duct or a gallbladder.
Exactly. I just want to study it for a second. Thank you. So I'm going to go really counter to see if I can get to the liver.
So
Because there's the bile duct, right? We see that. Okay, vessel. I may come back from the second portion as well,
I
just to
think
look
so.
at.
I think maybe follow the bile duct backwards to the cystic duct takeoff.
Yeah.
Yeah.
It's just hard to differentiate which one is which because they both seem to come and go out of view at the same time.
And they both are dilated.
And they're both dilated. So, but I think if you look at this structure, it's definitely bile
That
duct.
looks like bile duct, yes.
And there's papilla, there's PD, and right here,
That's
I think
a
it's the
stone
bile
in there.
duct, right?
Yeah. That's a stone in the
In
bile,
the bile duct, and
yeah.
and below it, exactly, and the below it is the cystic,
Cystic
duct,
duct.
remnant. So they were questioning a lesion concerning for malignancy going into the liver. I'm not necessarily seeing anything here, but feel free to let me know if you see something. I would maybe just start with an ERCP because all those LFT patterns may just be because of a bile duct stone. And we can see if there's a stricture on cholangiogram. She needs an ERCP anyway. Okay, the other thing you want to look at, that's good, you're doing really well.
There
okay.
are lymph nodes around, so I don't know what they were seeing, those.
Yeah, but these, I mean, this to me looks reactionary benign because
benign, yep.
it's very hyperechoic. Okay, mixed terminology, guys. Mixed echogenicity with a hypoechoic border and a hyperechoic center. Malignant lymph nodes will not usually have this appearance. They will be diffusely hypoechoic. Lymphomas can be tricky because they can have any kind of appearance, but they just may be very enlarged. So, but our suspicion for lymphoma is low because we have a lesion that may explain both her symptoms as well as her LFT abnormalities.
And Mustafa, also in this one, it's nicely, you can see the 3 layers of bile duct.
Yes.
And that's where it looked like it might have been a gallbladder.
Yes.
So when you can see the 3 layers of bile duct, usually the intestinal wall has 4 layers. The bile duct has 3 layers. So when you see those prominent, usually it indicates inflammation. It's an inflammatory process.
So the other thing is you want to follow your pancreatic duct and bile duct to the papilla, right? So now you have it here, and now you're going to go the other way, go clockwise towards the papilla, okay? And you're going to look for the pancreatic duct going into the duodenal wall. This is your muscularis propria, and this is where it's going to drop into this, and there's your duodenal lumen. So that's where, this is where the sphincter is, right there, okay? So I want you to, the other thing, yes.
Can you follow cystic duct further or know where it ends?
Well, we saw it coming together. You mean towards the...
towards the, like a
other
stump.
side?
Yeah, that side.
Right there.
Yeah.
Right. I had it for a second and then I lost it.
Yeah, we did see that. It looked like a...
I'll try again. It's just the scope there. I have to make sure so it's the opposite of what I'm doing. Right here.
Yeah. That's where it ends. That's the... what is that? That's the remnant?
I think I'm
That's
just
the
seeing a double view, yeah, but that's the gallbladder remnant.
Yeah, that's the remnant right there. So there's mass in there, definitely.
Yeah, and I don't see, the other thing is you can see how much like torquing I'm having to do with the scope. You just have to be gentle. But my left hand is facing the, well, it's going all the way down. So that's just, the main thing with that is in the bulb you sometimes need to do these maneuvers, but you have to be gentle with the tip of the scope. It's a long remnant actually.
Mm-hmm.
Okay, I just want you to go ahead and, we're going to find the stone and you're going to follow it towards, you're going to go clockwise to follow it towards the Papilla, and then you're going to do the second portion. So if it's slightly to your right, do big wheel towards you.
Mustafa, we're just going to go over the next case, so you
Yeah,
guys
yeah.
keep working.
Good, thank you. Okay, go clockwise. You've lost your thing, right? So go counter. Find it again. Okay, now big wheel towards you. Good, bring it to the center. Now go clockwise. There the PD, you saw that?
Yes,
Go
sir.
counter, that's the switcher. Keep going counterclockwise, keep going counterclockwise, keep going counterclockwise. There's the pancreatic duct, keep going counterclockwise. Bile duct with the stone. Okay? And you will see the pancreatic duct will go over the portal vein.
Look,
Go the
like
other way.
wall
Keep
layers
going
of
the
the
other way.
bile duct, they're so clear.
Yeah,
there.
right there.
So you
So
don't.
that's inflammation. Keep going counter. Keep going. I want you to follow the pancreatic duct. Keep going counter. You're seeing the pancreatic duct going over the portal vein, right? You keep going, keep going, keep going, keep going, keep. There you go. So that here was the PD going towards the. You're up in the bulb, looking ahead, and you just follow the pancreatic duct go away from you, and that's the tail of the pancreas this way. This is your confluence coming in again. Here, that was the portal vein, and there's your splenic vein going down this way. Okay?
Okay, sir.
And if you go clockwise, it becomes the SMV. This thing will come with repetition. Now keep going clockwise, and that's your SMV now. And so, there you go. Good. SMV, and behind that is the SMA. You see now, what you were saying, the structure of the vessels is different. This is a thicker wall arterial structure, and this is a thinner wall venous structure. Okay, let's go to second portion. I want you to do second portion. So what you're going to do is smaller to the right, smaller to the right. Don't worry about your endo view. You have to, if you're in that bulb, are you in the bulb?
Yes, sir.
How do you know? I guess you don't know because you can't see anything. So pull back. Okay, there. Section. Get rid of those levels. There you go. Okay, now smaller to the right. Smaller to the right. Don't worry about your endo view. When you're using an EGD scope, are you worried about your endo view from the... No. Okay, so smaller to the right, big wheel towards you. There you go. Big wheel towards you. Smaller to the right. Keep doing that. And there you go. It's just like EGD. Every scope's going to do the same thing. You're going to do smaller to the right, big wheel towards you. And you're going to reduce your scope. When we do EGD, don't we reduce our scope in the duodenum, right? That's what I want you to do here. Reduce it. G. Okay. We're just going to do the second portion. तो बाकी मैंने तो देख लिया sir. And there's no mass. So, good. Now pull towards you. Now you have to distend. Why can't we see the lumen, right? So you have to distend to see what's going on. There you go. So there's a role for distension when you need it. Because now you're doing endoscopy. For ultrasound, you can section again. So, okay, relax. Okay, pull the scope back towards you. Big wheel towards you. That tip is going to go into the back wall. You don't want that. So, yeah, pull back. Good. Keep pulling back. Keep pulling back. Good. Where's our papilla? You see it? I don't see it. Pull back. There we go. Now let's looking familiar for papilla. So keep pulling back. Section. Get rid of those levels. Good. Section. Okay, look at that. Slow down. Looks a bit like papilla area here. Keep pulling back. Go clockwise a bit. Okay, it's getting even warmer. Go counter. Good. There you go.
This one.
That's your papilla, right? Okay, usually I will actually look for an endoscopic view and take a picture. Because that's a prominent papilla. It looks benign. No, okay. Now what you're going to do is go clockwise. Big wheel towards you. Section. Section. Big wheel towards you. Big wheel towards you. And you're on pancreas. Big wheel towards you. More.
Fully.
Okay, good. Now pull back the scope a tiny bit. And right away you see the pancreatic duct. Go clockwise. Good. That's the way to do it. That's it. Keep going clockwise. Keep going clockwise. You have bright pancreas, which is uncinate. Okay? This is your bright uncinate. Keep going clockwise. Keep going clockwise. Keep going. That's your mesenteric vessels. When you see mesenteric vessels, you're good for pancreas. There's the border of the pancreas. That's your uncinate. Now go counter. Now you have dark pancreas. That's your ventral pancreas. So
Okay.
pull back a tiny bit. Keep that big wheel towards you, okay? Go clockwise again because you lost your pancreatic duct. Keep going clockwise. That's your pancreatic duct going into the papilla.
Okay,
Now go
sir.
counter. Good. Keep going counter. You've got very good movement here. Good. Keep going. Bile duct with, what is this?
Stone.
Why is it a stone?
Sir.
What's
Shadow.
the appearance?
Shadow.
Shadowing? What else? Hyper or
Hyperlucent.
hyper or hypo?
Hyper.
Hyper what?
Lucent.
No, it's not.
Intense.
No. Echo.
Hyper.
Echo endoscope. Echo
Okay.
ultrasound, right?
Okay.
Hyperechoic shadowing stone in the bile duct. Good. Go clockwise. Good. Keep going clockwise. There you go. There's your pancreatic duct.
Yes,
Now
sir.
you, whichever duct or pancreas you want to follow, you just keep doing that. So go clockwise. Okay, good. Now that's your towards your uncinate. Now go counter. You can pull back a bit. Keep pulling back a bit. Go counter more. Stay this, stay this. Okay, now go. There's your pancreatic duct. Good. Go counter. The other way. Other way. Other way. Other way. Other way. Good. Keep going. Keep going counter. Keep going counter.
Yes, sir.
Keep going more. That's the pancreatic duct. Keep going. There's your.
CBD.
Good. So for bile duct, you have to go counter.
Okay.
There's your cystic sort of wall, the duct to the cystic duct. That's the transition. Okay, we're gonna fall here, but that's okay. Go clockwise. There's your PD. Good. Now try and follow this pancreatic duct up to the right. So gently keep going clockwise. Relax. Go counter. There's your pancreatic duct now, right? Now keep big wheel towards you. Keep big wheel towards you and go clockwise a bit. Pull back a bit. There, you're going to go over the portal vein. I have never had a trainee do this in their 3-day course. You just followed it from the papilla all the way to the body.
Okay.
Okay, pull back, relax. Pull back your scope. Pull back, pull back. Maintain this to pull back a bit. It's going to fall on you in a second. Pull back. Keep pulling back. Keep pulling back. Good. Maintain that view. That's it. Keep pulling back because it's ahead of you. So you have to keep it. Now go clockwise. Now keep pulling back. So it's falling from you. Keep pulling back. Keep pulling back. Keep pulling back. Keep pulling back.
Okay, sir.
There you go. You're going to follow this PD, right? So keep pulling back. Keep pulling back. That's good. Go counter slightly. There's your PD. Good. Keep falling back. Keep going. Keep going. Keep going. There's your PD. Keep going clockwise. Keep going clockwise. Okay, go slightly counter. There's your pancreas. The other way. There you go.
Okay.
There you go. There's your duct. Right? You see it, right?
Yes, sir.
Good. Keep going clockwise. Follow that duct. That's your trail to the money. Okay? You just want to follow the trail. And the trail is your pancreatic duct. You just follow the pancreatic duct from the
Okay.
papilla to the tail.
Tail.
100 points. MashaAllah, very good. Okay. Ho gaya. There's nothing much more to do, right? We saw everything. So let's band karna hai. I think oh, you want to do mediastinum? Okay. Liver. Liver, 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 liver. Okay. IVC, right hepatic vein. And once you're up here, you start seeing the beating heart. Okay? There is a bit more big wheel towards you. And you have your, what is this?
Left hand, sir.
Good. And what is below that? What is the left atrium going to?
Left atrium. Left ventricle.
Left ventricle. Okay, which valve is that? Left ventricle,
Left ventricle.
left
नहीं।
ventricle, left atrium, left ventricle के बीच में कौन सा valve है?
Well, sir. Left ventricle.
कौन सा valve होता है यार बीच में atrium और ventricle के बीच में?
Mitral है, sir.
Thank you. ट्रिक क्वेश्चन नहीं है ये. और अच्छा ये क्या है फिर? What's that from the left ventricle going up? ये कौन सा valve है? इतना तो हमें पता होना चाहिए ना for our EUSs. Ventricle से हम किस चीज़ में जा रहे हैं?
सर वेंट्रिकल से हम जा रहे हैं
लेफ्ट वेंट्रिकल कहाँ को ब्लड भेजता है?
एयरटा
वेरी गुड। तो और एओर्टा के लिए कौन सा वेल्व होता है? ये ट्रिक क्वेश्चन नहीं है, मैं आपसे वैसे ही पूछ रहा हूँ। कौन सा वेल्व है? एओर्टिक वेल्व। तो बस ये आप पहचान लेना। ये देखें, लेफ्ट एट्रियम, लेफ्ट माइट्रल
वो जो आपने
वेल्व,
साइन बताई थी डबल,
ये डबल है ना। तो ये जो है ना मेरा फेवरेट व्यू है पूरे अल्ट्रासाउंड में। और साथ ऊपर इज राइट पल्मोनरी आर्टरी,
सन ग्लास साइन बताए।
वो आ गया है, वो भी नहीं, वो ये नहीं, वो भी नहीं है। सो देन यू जस्ट लाइक लुक, इफ यू गो क्लॉक यहाँ पे, दिस इज द, अब ये ट्रेकिया आ गया। सो द ट्रेकिया विल हैव शैडोइंग because of the air, so you can't see anything. And if you spin around here, you're looking for lymph nodes. That's your level 7. ये जिससे these are small little lymph nodes, okay? So atrium artery के बीच में you're looking for these. In cancers, these can be very big. Okay? Now you have your aorta. That's vertebrae. You see the bone?
Yes.
Vertebrae. Okay? And you're going to look for your aorta. So you keep going across. There's your aorta, and it has a shadow. Now, when you come back and you pull back and go big wheel towards you, sometimes patients get uncomfortable here. These are the two eyes.
Two eyes.
Right पे है aorta, left पे है pulmonary artery, and that is here 4L, and below the arrow is 5. And you see there's little lymph nodes here, but these are benign. Okay, very good. Thank you. अच्छा, okay, that's okay. That's nice case.
चलो आप हैदराबाद आए ना,
मैं आना है यार, मैं आप लोगों को तो मुझे जो है ना साथ से मिलना है।
सर आएंगे
आ रहे हैं?
हाँ।
वेरी गुड। नहीं इंशाल्लाह मैं ज़रूर आऊँगा। मेरा मेरी फैमिली के लिए दीनाबाद है।
Not too bad of a position. It's a landing. ठीक है, एक दफा योटा आपके व्यू में आ गया, थोड़ा सा स्टॉप हो गया। अब जो है ना, we are very close to the GE junction right here, ठीक है। आपको एक चीज़ नज़र आ रही है, इसके ऊपर ये एक ट्रायंगुलर शेप नज़र आ रही है, ये छोटी सी, if you can imagine that right here, that's the diaphragm, ठीक है। हाँ, तो इसको हम अनफ्रीज, तो एओर्टा को दोबारा लेके आओ। Good, excellent. आप gently advance करते जाओ while you have a aorta in your view. Release the wheel a little bit. Big wheel away from you. Big wheel away, right there. आपका celiac नज़र आया वहाँ पे? Celiac take a, ठीक है? तो कई दफ़ा sometimes celiac comes off the side of the aorta, not exactly in the front. So you just rotate a little bit while keeping that in your view, the whole aorta in your view, to make sure you don't miss the takeoff of celiac, ठीक है? Once the celiac is here, we're going to go to the right, we'll go back to the celiac, right? Right there is the celiac. From there, gently, अब जो है ना, आपका वो celiac जो artery है ना, is trying to go to 7 o'clock position. So what we'll do is, we'll gently advance the scope, not too much movement, just keep it at 6, keep rotating to the left and stop there. You see that on the right side a vessel is coming off. This is a left gastric. ठीक है? Or then go further to the left. Okay, stop there. You see there is a bifurcation again right there. एक ऊपर की तरफ जा रही है और एक नीचे की तरफ आ रही है. You can clearly see that. ठीक है? Right there. अब यहाँ से ये left gastric take off. Go a little bit to the left, or one is going downwards because it's going away straight from there so that's why you don't see a longitudinal. ठीक है? तो but this is the splenic artery now. ठीक है? अब splenic artery हमें नजर आ गया. Just the only thing you need to do is move the big wheel away from you. Move the big wheel away. Big wheel away. आपका pancreas. The only thing you did was just move the big wheel away because you're looking like that. So move the big wheel away so it can see the pancreas like that. Goal right now is this is splenic artery. This is splenic vein. We need to bring that to the right side of the screen. So how would you do that? Just push the scope in a little. Okay? Rotate to the right. Okay. Right. This is the perfect position for these splenic vessels. Okay? Splenic artery ka course, that is a zigzag sometimes. You may see the splenic artery in the same plane twice. That can happen. Okay? On the other hand, splenic vein, that makes the bed of the pancreas. It's right. अगर आप CT को देखोगे कई दफा, you see the splenic vein just sitting right underneath the whole pancreas, right? So it makes a bed of the pancreas. ठीक है? अब we will advance gently there. This is all our pancreas. The duct is quite small there. We don't even see clear very well that duct, which is okay. But we know that this is all the pancreas right here. ठीक है? अब rotate करो towards the right from here. Keep the clockwise. Keep the pancreas underneath, right there, gently. Keep rotating slowly. Keep going to the right. Right. Keep going. Keep going. Keep going. You still have your pancreas. Slowly. अब यहाँ पे थोड़ी देर के लिए रुक जाओ. There's something coming up here. ठीक है? This whole area, that's your kidney right there, left kidney. ठीक है? अब चलते जाओ. Further to the right. Keep going and gently pull the scope back. This is your spleen right there. ये spleen आ गई ना? नजर आ रही है spleen right there? ठीक है? और this is still your pancreas right here. This is your left kidney. This is your spleen. Spleen, kidney. Spleen, kidney. ठीक है? And pancreas tail is tucked in between the spleen and the kidney right here. तो जब आपको दोनों ये नजर आ जाती हैं, sometimes you have to release the wheel just a little bit and rotate to the right. So this is really your pancreas ends right there in this case. ठीक है? अब kidney आ गया. This is a part of the pancreas. These are your splenic vessels. अब जो है ना anti-clockwise चलते जाए. ठीक है? Okay. Just gently advance the scope because pancreas is trying to run away from you. Good. Excellent. अब चलते जाओ left की तरफ. Now it's trying to run that way. So pull it back. ठीक है? ये आपको नजर आ रही है? That's the pancreatic duct. अब थोड़ी ज़्यादा prominent होगी ये देख रहे हैं? यहाँ पे this is all pancreatic duct, and if we put a Doppler on there should not be a flow in there. ठीक है? ये pancreatic duct, when it falls down, that's where it's the neck of the pancreas. You see that? It's coming like that. So इसमें now other thing which you see is, let's pull back a little bit. You see that? That's a splenic, right? Splenic vein, splenic artery, splenic vein, SMV, superior mesenteric vein, splenic vein, superior mesenteric vein. They're getting together, making a portal vein. Portal vein, now the liver is right here in this area. When you are in the duodenal bulb, liver is on the top. So here the liver is at the bottom. Okay? Because just imagine you are looking at it from the top down. But when you are in the duodenal bulb, you are resting on a greater curvature and you are looking upward. So सब कुछ flip हो जाता है, ठीक है? So here, let's do one more time. That's splenic vein, splenic artery, mesenteric vein, SMV, splenic, SMV, portal. And on the other side of the portal is usually the bile duct, right here, ठीक है? When you see that from the stomach, ठीक है? लेकिन ये सारा फ्लिप हो जाता है आप जब डुआर्नल बल्ब में होते हैं. उसमें पहले आपकी SMV जो है वो इधर आ जाती है, आपकी बाइल डक्ट इधर चली जाती है, पोर्टल वेन ऊपर चली जाती है, ठीक है। दैट पोर्टल वेन गोes up here, bile duct is going to be there, and your splenic is going to be here. So everything flips in the duodenal valve. So just this is the hardest concept to get, okay? That sometimes is confusing for people. So this is nice view, really nice view right here. Splenic, SMB, making a portal vein. And if we follow the portal vein right here, by that I mean just try to keep the portal vein in the center of the screen. Sometimes you have to move the big wheel towards you a little bit, right there. We're going to pull the scope back, keep that in view. Perfect, the way you're doing, perfect. Keep doing that. You see that?
Yes.
Liver is coming, liver hilum. Okay? You can get to the liver hilum, big wheel a little bit towards you, little bit. You can get to the liver hilum right from the stomach. And you see this structure underneath? Bile duct, common hepatic duct basically. Okay? So that's entering right into the stomach right there. That's your portal vein. This is your liver hilum right there. अब इसको दोबारा follow करो towards the where we started. So right there. So gently advancing the scope, and we're back to the ठीक है? So whatever you want to follow, sometimes you have to pull, push, right torque, left torque, maybe wheel away from you, wheels towards you. It's a very, very small movements you have to do. And just if you follow one principle that whatever you want to examine, just keep between 5 and 7 o'clock position, and whatever it takes to do that, just do that. Right, ठीक है? कई दफ़ा स्कोप को आगे पीछे राइट लेफ्ट जो भी करना हो मैंने उस स्ट्रक्चर को वहाँ पे रखना है और उसको उस तरीके से फॉलो करना है. तो दैट्स व्हाट यू नीड टू डू. ठीक है, अब चलें, ये तो हो गया हमारा स्टमक से हो गया सारा कुछ. दिस pancreatic duct right here going down. Now coming around the portal vein, when it gets around the portal vein, that means it's going to the head of the pancreas. ठीक है, okay, let's go to the वो endoscopic view कर दो. Let's go to the duodenal valve. जब भी आप यहाँ से आप स्टमक से बल्ब में जाएंगे तो इन्फ्लेट दस को स्टमक. ठीक है, इन्फ्लेट करो, उसमें CO2 डालो, चलते जाओ. गुड जॉब, एक्सीलेंट, कीप गोइंग. ओके, थोड़ा सा सक्शन कर लो ताकि आराम, जस्ट अ लिटिल, दैट्स इट. ओके, कंटिन्यू. सो कीप इट. यू रिमेंबर दैट वी टॉक्ड अबाउट के transducer is like 1.5 to 2 centimeter away from the camera. So here, big wheel towards you. Okay. Now gently advance. Like ERCP. You will be right in there. ठीक है? Gently advance करो. And once you get into the duodenal valve, then stop there for a second. ठीक है? There you go. ठीक है? थोड़ा सा और advance कर लो. You are just stuck in the pylorus. ठीक है? Small wheel away from you. Okay, stop it. Okay, ज़्यादा नहीं, इसको अभी नहीं reduce नहीं करना. ठीक है? तो we just went a little bit deeper. We don't want that. We want to come back a little bit. ठीक है, right there is fine. तो अभी एक मिनट ठहर जाओ. आपको नीचे duodenal apex थोड़ी सी नज़र आ रही है ना नीचे कॉर्नर में. ठीक है, yeah, we don't want to see all that. ठीक है, but you need to know where that is. Now the goal is to put the transducer in left upper corner. So what you would do is rotate the scope a little bit to the left, big wheel towards you, and suction. Okay, अब इसको यहाँ पे बैठ जाना. ठीक है, अब ज़रा करो. You will always end up on one of the three structures or two of the three structures or all three structures. ठीक है, अगर मैं यहाँ पे डॉपलर डालूँ, ओके, थोड़ा सा रोटेट करो लेफ्ट की तरफ या राइट की तरफ. राइट देयर, आपकी बाइल डक्ट, आपकी पैंक्रियाटिक डक्ट, आपकी पोर्टल. So when you put the transducer in duodenal apex, left upper corner, big wheel towards you, that will take you to one of these structures. So once you find one, it's easier to find the rest. ठीक है, तो यहाँ पे अब big wheel a little bit away from you, just a little bit. Rotate the scope a little bit to the left, and now pull the big wheel towards you, right there. ठीक है, आपकी bile duct यहाँ पे है. It's not, you can get a nice idea, pancreatic duct, bile duct. ठीक है, अब let's follow the bile duct towards the liver. You will keep rotating to the left, anti-clockwise. Okay, अब ये इस तरफ जा रही है. ठीक है, that means you need to pull the scope back a little bit. ठीक है, big wheel towards you, right there. अभी bile duct है, keep going to the left, keep going, keep going, keep going. Now release the wheel just a very little. Keep going, okay? Keep going, keep going, keep going until you end up into the liver hilum, okay? So we kind of lost that there, which is okay, and that's a portal main. Keep going to the right now from here. Okay, right, clockwise, okay? So आपकी bile duct वापस, okay? Pull back a little bit. And big wheel towards you, big wheel towards you, big wheel towards you, right there, ठीक है? थोड़ा सा आप पीछे की तरफ आ जाते हैं, ठीक है? So you just need to be able to maintain, find the problem, ठीक है? What is the, and then you will be able to fix it, ठीक है? What happened is like you fell back from the dormal apex. So just needed to push it, your scope in a little bit. You see the bile duct right there? ठीक है? I'm going to rotate to the left. No, other left. Okay. So stop there for a second. Release the wheel just a very little. Good. Now further rotate to the left. Okay. Further. Release the wheel just a very little. Sometimes when the bile duct is really close to the transducer, you just compress it. ठीक है? तो ठीक है. अब दोबारा वापस जाओ. Okay. Okay. Keep going. Keep going. Keep going. Keep going. Excellent. Keep going towards the ampulla. Keep going. Keep going. Push the scope just a little bit. Right there. Keep going. Stop there. Keep going to the right. Keep going. Keep going. तो आपके यहाँ पे कहीं पे end over here. But you got the idea, got the concept of completely that. ठीक है? तो now let's do this. Let's go to the D2. ज़रा उसको endoscopic view कर दो. Okay. Endoscopically, just keep going. Good. Okay. अब short scope position कर लो, just like you're doing a ERCP. ठीक है? तो yeah, pull it back. Good. Rotate to the right. It's okay. Just small wheel away from you. I think you are way too far in there, so you won't fall back. Just pull back. It's fine. Keep pulling. Keep pulling. It'll go back. Keep pulling. Keep pulling. Good. Excellent. Okay. ठीक है. Good. Right there. ठीक है. Small wheel अगर आप away करोगे तो फिर okay. Small wheel a little bit further away. I think it's just unstable. The papilla is right there. और थोड़ा सा push करो. Big wheel towards you. Big wheel towards you. कोई बात नहीं. हाँ. Gentle. Right there. ठीक है. Up small wheel away from you. You can lock it for a little bit, but we can unlock later. Okay. Okay. Well, you see the papilla right there, huh? Okay, this is better. Okay, अब unlock कर दो. Okay, तो big wheel towards you. Okay, और suction कर लो. Suction. अब चले जाओ उसके ऊपर में. So here, even though you are looking at that papilla, right? But your transducer is distal to the papilla. So big wheel towards you, suction, and now pull the scope back a little bit. So here, the goal is to find aorta if possible. ठीक है? अगर papilla नहीं मिल रहा है, तो just find the aorta. You see where the aorta is? Right there. ठीक है? You are right onto the aorta, and that's usually the goal. That's in the center of 5 structures. Okay? On the left side, IVC, further left, right kidney. ठीक है? On the right side, the pancreas will come, but you're looking for the bile duct and then pancreatic duct. So we're gonna follow that. ठीक है? So here, this is a aorta. Okay? Go to the right a little bit. Right torque, right there. ठीक है? ठीक है? थोड़ा सा स्टेप पीछे कर लो. ठीक है? Right there, right? अगर यहाँ से आप लेफ्ट जाओ, आपका IVC. ठीक है? अगर आप further go to the further left, either you will find a right kidney or the segment 6 of the liver. We see the segment 6 of the liver here. Go to the right from here. Right. Other right. Clockwise. Okay. IVC. Go further clockwise. Aorta again. ठीक है? अब थोड़ा सा पुल करो स्कोप को. ठीक है? and rotate from aorta just further clockwise. That's still IVC. That's aorta now. And stop there. I'm going to put a Doppler here. Your bile duct. ठीक है? Bile duct आ गई. अब further rotate करो right की तरफ. Further. ठीक है? So we did not clearly see PD, but that's a very small one right there. ठीक है? Okay. So this is there. Hold on. That's a vessel there. Okay. Bile duct right there. ठीक है? Aorta, IVC. चलते जाओ to the right torn. Stop there. Okay. It's a very small PD, which is not very clear, which is okay. So, but these are the mesenteric vessels as well. So this is your uncinate process when you start seeing the mesenteric vessels. So basically, aorta, you found the aorta, that's a IVC, that's a bile duct, this is your head of the pancreas. PD is not very clear. I think it's a very small right there. Okay? Right.
How about going clockwise from the bile duct to look for deletion?
Yeah, that's also a possibility. Okay. So if we pull back, okay, right there, not very clear PD. If it is a divisum, you would see a separate pancreatic duct or opening right
PD.
in this
There was a
area.
bit of PD right there.
Yeah.
So here, that's
Yeah,
the PD.
that's a.
So that's the PD right
Hold
there.
on. Yep. Right there it is.
Right there, there's
Yeah.
the PD. now.
Yeah, there it
so
is.
you can see, I think it's just getting compressed.
It is. Bile duct
Yeah.
right there,
There's right.
and the PD is right there. So it's a normal, it's not a divisum
Yes,
basically.
Yeah.
And so what Mustafa's point was, if you don't see the PD clearly, you start looking for, make sure that there is no separate opening of the PD. In case of divisum, the PD will come here, follow this, and it crosses the bile duct and opens right here. ठीक है? तो वो pancreas divisum होगा. ठीक है? Here we see a clearly PD right here, and this one is the bile duct. It was right there is the PD. ठीक है? अब यहाँ से just forget about everything else. Just pay attention to the PD right now. ठीक है? ये वाला हमने देख लिया. अब make sure none of the wheels are locked. ठीक है? Unlock उन सारे wheels and just big wheel towards you, gently. We are going to follow just the PD right here, and while doing that, we will keep pulling the scope back right here. You see the PD here? अब इसको भूल जाओ, ठीक है? Gently release the wheel just a little bit so the scope can fall into the stomach, because we're coming to portal confluence from the stomach. Right? So right there, we fell back into the stomach, right? You felt that like it came back, right? And then you pull back a little bit further, and that will take you to the pancreas right there. Okay? So release the wheel a little bit, big wheel away from you, and then you can adjust yourself and then go rotate to the right from there. Keep rotating, keep rotating, keep rotating, keep rotating, keep rotating. To the right, keep going, keep going, keep going, and your spleen is right there. So up from D2 all the way, you can see the whole pancreas. Follow that from the ampulla, pancreatic duct, all the way through the head, to the neck, body, and tail. Okay? So now we need to, let me take a look at it. I think we're looking for some lymph nodes, right? Yeah. ज़रा end of view पे चले जाओ. I didn't see any lymph nodes there into the duodenum from the periportal lymph nodes. So I think we may just. So ये जो है ना, when your a scope is locked too tight, that's what happens. A lot of blood, huh? Gotta make sure there's no damage there. So I'm just making sure that there's no duodenal wall damage there. इसलिए जब वो when you're coming back here, if your wheels are locked, they can be really traumatic. And they can even cause, if it gets hung up, it can even cause a perforation too. So, but this looks okay. I don't think there is any problem. See, just was a trauma. अब चले जाओ उसके ऊपर ज़रा. See, you see the aorta right there, ठीक है? IVC right here. If I go further to the left, either that's a right kidney is coming up right in this area, right here, ठीक है? IVC, okay, aorta pulling back, bile duct right there, ठीक है? Going to the right, and that's a PD right there. You see? ये वाली हम देख रहे थे. I did not see any. Let me take a look at from the bulb. If not, then we'll go to the chest and then biopsy. We should be able to find something there. Okay. That's a portal vein. So what I'm looking for is any periportal lymph nodes here, which I don't see all the way. Okay. Going. There's a small lymph node right there, but it's really small. I'm not sure even if it's worth going after. You देख रहे हो? Very small picture. Okay, चले जाओ वापस. Okay. Let's take a look at the mediastinum actually. Okay. There is a big lymph node right here, but looks very benign. अगर बायोप्सी करनी है इसकी lymph node की, चलो ला दो फिर मुझे. ठीक है, चलो let's do a FN. हाँ ठीक है. FNB needle दे दो.
पिक्चर लेनी है भाई.
ये देख लो, साइज देख लो इसका. .8 by 1.6. हाँ. वो डॉपलर हटा दो. Size आप subcriner के lymph nodes, you can find a huge big lymph nodes in there.
थोड़ा बताइएगा जैप
So,
कैसे करते हैं.
so like this is I don't know if they can see the on the camera. So yeah, so the way I put the needle in there, if you look at this, these wheels are facing wheels of the needle. They're facing towards me. So it needs it's nicely rested onto the working channel. Now I rotate it, and when I rotate it, you see that how they ended up to the right side of that, my hand, right hand. So what I'm trying to say is, like, if I start these wheels from bottom up, they are going to go and end up towards the scope. Okay? So it always, every single needle, when it is nicely, freely rested onto the working channel lock, if the wheels are facing towards you and that's where you start, it takes 3/4 of a circle and they always end up on your right side. Here we can do this one too, which is fine, but to make everybody's life easy, wheels facing towards me, it's nicely rested on the working channel lock. I rotate and the wheels always end up to the right side. Okay? So that's easy for me to open and work on those wheels. Okay? So this is a big lymph node. It's very close to the left atrium. You see the left atrium is right at the bottom. So have to be careful. Hold karo scope ko. And you can ask your tech to hold the scope if needed. Just have to be careful that you don't have an uncontrolled stab there. puncture. Here I do see that sheath a little bit. I'll unlock that, control my sheath, and then needle. You can see right here is my needle.
Middle के आगे picture
You see that? Very controlled. Just I did a little bit puncture there, and because the heart is right there, so you just want to make sure that you have a full, a full view of that needle tip, so it does not puncture beyond. And mediastinal, by the way, is the easiest area to biopsy. And I've seen people that they do a very quick movements with the core needle. Look at my movement, that's how I do. Like with the core needle, you want to do a slow movement because you want it to be able to cut the tissue and get that tissue into the needle lumen. So here, you can do a faster too, but I think you cut better when you are doing it a slow movement. And here I've done like 6, 7, 8. Usually you don't have to do that, but I think we should have a good tissue in there. And let's see what we find in there. So once you are done with the FNA, always make sure that you release the elevator, because you don't want to pull the needle when the elevator is on. What would that do is that would bend your needle like this. So always before you pull the needle out, make sure your elevator is unlocked. So I'll pull that needle out. Make sure you lock the needle before you give it to your tech. कैप दे दो, ये ले लें टिश्यू वसीम। मुझे अब ये ना बताना कि टिश्यू नहीं है, इतनी मेहनत की है मैंने। That's like a homogeneous lymph node, triangular. There's a whitest band around it as well, and I think it looks like a normal inflammatory lymph node. Does not look like a malignant lymph node. And in subcarina, you can find big lymph nodes, conglomerate of the lymph nodes mated together sometimes. In subcarina, it's easy to find big lymph nodes. Fibrous band usually indicates a benign. Yeah. Any questions while we? Tissue है या नहीं है? Huh? Okay, we can get some with the suction, if not.
I think a question for the sort of faculty here in Pakistan. In America, we will often send these for flow cytometry just to rule out lymphoma. What's your usual approach with enlarged lymph nodes?
That was question for me or for them?
For them.
Oh yeah, okay. That's what I thought. इसमें है कुछ या नहीं?
नहीं वो
For
उसमें
okay,
कुछ
so
था,
saline
सही
for
निकला था।
so they send for
निकला है?
TB.
अच्छा.
They do send for TB on a regular basis and for formalin.
Yeah, that TB goes in formalin?
Saline.
Saline.
Saline. And usually, how many passes do you do here in this type of situation? Okay.
पकड़ लो इसको.
Okay.
हाँ कर.
क्योंकि वहाँ पे this say for the small cell lymphomas we do flow cytometry.
इसको पकड़ के रखो
यहाँ नहीं
यहाँ पे.
करते।
नजर आ रहा? ठीक.
The other point, I apologize if I missed it. The esophageal wall is very thin, so you don't have to use a lot of force to get the needle across. Sometimes gastric wall, based on the angle, you may have to use force to puncture through. So obviously you have the heart behind, so you want to be careful. And secondly, generally you don't need a lot of force. And you can see Dr. Hassan's constantly trying to keep that needle in view. So every time he loses view, he stops and he changes his angle. So it's the
आप
tendency
इसको ना थोड़ा सा
is
रोटेट करके ना
to
नीडल
just
व्यू
keep
में
going
रखो,
back and
ठीक है,
forth.
राइट
But you want to see that tip of your needle wherever you do FNA. Always try and visualize your needle, not just hope that you're in the right place, but visualize being yourself in the right place. RPMI, हाँ RPMI. अब I don't know इसकी cost क्या है और oh अच्छा, it's a lot. उसका कई बार ये कहते हैं कि आप ले लें, but they won't run it till they've reviewed the other. But I thought RPMI also is time sensitive. You have to run it right 24 hours. So I think sometimes they'll take the specimen but not run it till they have looked at the pathology.
तो
If
जब
it's
वो
negative,
नीडल
they'll
निकाल
run
रहे
it
हैं
for
तो आई
complete
हैव
resection.
कॉन्स्टेंटली I'm on suction, नहीं तो अगर सक्शन पे नहीं होगा तो व्हेन दे पुल द नीडल आउट दिस कुड बी स्प्लैशिंग आउट, तो हमेशा जो है ना सक्शन पे अंटिल द कैप गोज ऑन एंड देन आई लेट इट गो, ठीक है। एक मिनट जरा पकड़ना, थैंक यू।
हमें भी slides,
मैं दिखा दूँ,
जी।
आई विल शो यू द स्लाइड्स आफ्टर वी मेक इट।
both your like gross specimen in the as well as your
स्टॉप
slides.
स्टॉप
स्लो स्लो आते हैं
स्लो स्लो चलते जाओ। ओह दैट्स अ लॉट ऑफ टिश्यू नाउ।
गुड इनफ
काफ़ी है मेरे ख्याल में, इसकी स्लाइड बना लो फिर। आई थिंक वी हैव अ लॉट ऑफ कोर टिश्यू, गुड टिश्यू देयर। वसीम इतना खुश है कि कह रहा है कि छोड़ दें आप इसको, तो आई थिंक लेट्स मेक द स्लाइड्स। हाँ स्लाइड बना रहे हो? अच्छा ठीक है ना, काफ़ी है टिश्यू। ओके ये पहले वाले से ठीक ठीक है सही।
So see if you can drop into the pylorus, yeah? No. Okay, just orient yourself, yeah, excellent. So as soon as the tip is in, you should be able to see the images, yeah? Yeah, push it in now. That's it, stop there now. Excellent. So now just orient yourself. So we did have a quick brief view of the bile duct. Can you see that? You can get some stones and some imaging is coming there. So there's a hyperactinicity. No, I think that is a bit of ascites probably. I think so. But because you can't have the, or it may be the gallbladder, I don't know, but there's some fluid-like structure, isn't it? So just in the first instance, let's just move the scope to the anti-clockwise. Just orient ourselves a bit. So you can see the blood vessels there, yeah? I'm going to just make it a bit small, yeah? Okay, now do a clockwise torque. Clockwise torque, yeah, keep on doing that. Keep on doing that. Yeah, you can see the bile duct coming on the view on the top, and there's a stent in it. Can you see that on the top? Just try to see if you can bring that into the center. And just below that, you'll have the portal vein. Okay, so we just missed it. Just push the scope in slightly because, okay, so that's okay. Clockwise torque, and pull the scope back. Okay. No, so we're just missing that area. So yeah, so just see if we can get this bit. Yeah. Yeah. Excellent. So I think we've just slipped out. Just see if we can get into. Yeah, that's the best time we will get to be excellent. So you can now try to follow the bile duct. So if you want, excellent, that's great. So you're getting a better view of the bile duct. Suck all the air out. Yeah, excellent. Keep on sucking all the air out.
G.
Gee, we're back with you.
Oh, okay. But I don't see the slide there.
Okay.
Okay. Can you put the slide on there? Yeah, yes, slide. Okay. So what I was showing is like if you look at that slide, it's hard to point from here. I can come over there later and I can show it to you. But there are a lot of lymph nodes there. There are RBCs, but there are, lymphocytes, a lot of lymphocytes there. And if you look in the right upper corner, there are different sizes of those lymphocytes. They are a little bit bigger than the other individual lymphocytes. What that really means is they are in different time of maturation. That is always an indication of a benign or inflammatory lymph node. I don't see any giant cell in this view, at least on this slide. That is an indicator of possible TB, but I don't see that here, any granulomatous cell there. So basically, if these are same size, single cells, and same shape, that would be an indication possibly a lymphoma, and in that case we'll send it for flow cytometry. Okay? Okay. And we got a lot of tissue in there, so I think that's good enough for both to rule out TB and flow as well. Okay. Thank you.
Thank you.
And this area looks a bit hypoechoic around it, around the lower end of the duct. And that's the PD. Can you see the PD? No, it's a plastic stent. So but that's because there's sludge and stone there as well, isn't it? So it's not a simple, just a stent thing. There's a bit of a stone and sludge there. So I'm just trying to see if we can get to the...
I think there's a bit redness with labulation.
Yes. So there's, what you're trying to say is that the pancreas doesn't look normal. There seems to be some,
Chronic.
so chronic. Yeah. So that's where the thickness is, in that area. So that looks like the abnormal area. Okay. So do you want to have a go? Want to have a go? Yeah. Excellent. So again, just see if you can find that area again. Yeah. Put some suction there. Yeah, excellent. So that's the stent. You can see the stent up here. That's the bile duct. See if you can follow that. So you just need to do a clockwise torque. The portal vein is just underneath here. So push the scope slightly in. Yeah. I think you just, because of the looping. Excellent. That's great. Yeah. So we've just lost the bile duct here. Okay. Do a clockwise torque and you should be able to see it again. Yeah. And just push it in. Yeah. There's the stent coming in again in the view. Yeah. You can see it here. Yeah. Okay. Keep on going. Push the scope in slightly. Okay, so you're getting the stent back into view, but so possibly, if you're in doubt, you can put the Doppler up, and if you see blood coming up, then it's not. But our CBD is a bit enlarged, and it has a stent in it, so you should be able to see it. That's the portal vein. That's the portal vein. Yeah. Okay. So keep on twisting it with clockwise. Clockwise. Do it clockwise to see. Yeah. Keep on going. 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 No. Okay. So just see if you can pull back slightly. I think you're too much deep in. Okay. Yeah. And then anti-clockwise. So it's a dynamic view. If you can't find yourself, if you can't orient yourself, then you just need to. So can you see that we just saw the image of the right kidney, which suggests that you know. Yeah. See if you can go back in again, just gently. Yeah. So if you see the pylorus is coming up a bit on the left side, so you can use your little wheel to drop in if you want to. Yeah. Excellent, that's it, stop there. You have good images now of that bile duct. So you've got the bile duct coming off here. Okay, there's a debris in it and the stent. You've got the portal vein there. Can you see the walls? They look a bit thickened. Yeah, and you can see the layers of the walls as well, you know. So there probably is an element of cholangitis going on in here. Yeah.
Sludge.
Yeah, and that's sludge or stone, you know. Okay. So if you put the Doppler up here, you can see the vessels and you can, you know, differentiate it very easily. Yeah, portal vein. So this is the bottom one is the portal vein, yeah. So yeah. So if you just follow that, now do a clockwise torque on that. Yeah, so if you can see there's a lot of sludge, again you're continuing to see the sludge there, yeah. Keep on going. Keep on going. So just try to reduce the pressure there on it. And you can see probably with the eye of faith the surrounding areas edematous and is becoming hyperechoic as well. And you can see the acoustic shadow. Can you see the posterior acoustic shadow that's coming down here? You can see the two parallel lines of the stent in the bile duct with the debris there, as well as the posterior acoustic shadowing. Okay. Now continue with the clockwise torque, and you should be able to see, you know, those two structures meeting up. So that's the pancreatic duct coming in view. That's the bile duct, and this area looks quite hypoechoic and thickened. Can you see the color has changed? So we probably will do some biopsies from there. So now keep on going. See if you can make those two join. Do a clockwise torque. So keep on going, excellent. Keep on going, keep on going. Yeah, so keep on going. Keep on going, very good. We're almost there, isn't it? So we're very close to the end bit. Excellent, keep on going. So there's a small chance you may slip, but that's okay. Keep on going. Can you see the portal vein is coming up from the back? That's the bile duct, the PD. Excellent, keep on going. Keep on going. Can you see this whole area is hyperechoic around the bile duct? Yeah. Excellent. Excellent. So very gently, yeah. Yeah. So if you're moving on that side, you can push the scope in slightly, and you can go. Excellent. Excellent. So we're just losing some of the images. I'll take the Doppler off so that you can maybe easy for you. Yeah. So your bile duct is somewhere here, and your PD is somewhere down there. I think you've lost that bit. Okay. Anyway, you've got good views. So do you want to do that again? So if you slip out. So the bile duct wall appeared to be thickened in that area, and there was hyperechogenicity around it. Could be edema, swelling as well, but you're looking for any tumors, masses there. Yep. Okay, excellent. So if in doubt, just put the Dopplers to see where you are. You know, the large vessels will come up with the Doppler effect on it. And sometimes, you know, just reducing the size may help you as well. That's the portal vein coming up, yeah. Keep on going. So that, again, you've got the CBD, yeah. That's the portal vein underneath it. You've got the good views of the CBD there. So push the scope in slightly and you should be able to get the CBD back in view. Yeah, it's just up there. Can you see that? It's coming up. So at this point, if you use your little wheel, sometimes you can orient it. So try using the little wheel at this point, you know, and then you can see that you can move the CBD without moving the scope too much, so you can orient it in a better position. Okay, so sometimes that's helpful, yeah. So PD is coming from below, yeah. Excellent. So we plan to take, I think we will take a biopsy roughly around that area, you know, because there's quite thickened. If you see You know, so if I just pause this area, you know, it looks quite. You can just, I'm just measuring this bit. So you can see 2.7. It shouldn't be that thick, you know, area. Sorry, what you saying? So excellent. I think we should biopsy that area. Guys, what do you think in the group? So this particular patient had some thickening of the lower CBD, possible mass there, 1 centimeter. Obstructive jaundice, has had a stent put in. We've had these views which seems to be the CBD around, surrounded by a hyperechoic area, which we plan to sample.
Can we keep going all the way down
Yeah.
to the papilla?
So let's see if we can go all the way down to see if we can join the PD and the CBD. Yeah.
So keep going clockwise.
Excellent. Just very slowly. Yeah.
Yeah,
Excellent.
keep going clockwise. Keep going.
Yeah. Excellent.
Keep going. Keep going clockwise. Keep going. You see the PD becomes dilated here too.
Yeah.
So keep going. Keep going. Here it gets even thicker. I would consider sampling about here. Keep going more. Keep going all the way till the PD disappears. I mean, I can't tell because it's bright rather than hypoechoic. It's hyperechoic. But considering the patient presented with jaundice, it makes sense to
Sample
and
where
there's-
the caliber is changed.
yeah, and with that degree of thickness, it makes sense to sample here.
Yeah. So I think we'll take some samples right from this area down there where there's a caliber change in the bile duct,
Right there, yeah.
and then we can do some as well from this hypoechoic area as well.
Yeah, and everybody's practice varies, but usually I'll do a second portion view first, just to see from the short position what things look like, and then likely do an FNA. But either way, I think you would end up sampling this.
Okay. So do you want to come in D2? Let's see if we can go into D2. Yeah. Excellent. So gently, yeah. So just use the little wheel, and then just twist all the little wheel. Yeah. Okay. So I. Okay. So use your little wheel, and then all the way. And then use like the ERCP, just reduce the scope. Just twist the scope, do a clockwise fork, and pull the scope back, and it should slip into the forward area. Excellent. So no need to push there. You can actually get it to slip down. So you're getting some views of the ampulla actually in the area. Let's see if there is a mass there. Yeah. So let's see at the base of the stent. So no, it's okay. And so endoscopically, there's no obvious big mass down there. So to see if you can now put the tip up, so you are actually roughly around the ampullary area, and that's the pancreatic, and snake is coming up as well. So tip up, and now move the scope slightly back, and you should be able to see the stent come into view. Yeah, now move the scope left and right, just clockwise, anti-clockwise, while pulling the scope back. Yeah. That's the PD, yeah. Keep on pulling it back. Yeah, keep on pulling it back. Yeah. Keep on pulling it back. Excellent. Okay. And just do a bit of a rotation as well, clockwise, anti-clockwise, so that you can see where the vessels are going. Yeah. Okay. Yeah. Anti-clockwise. Yeah. Yeah, keep on pulling back. So that's where, can you see the stent is coming in view? Yeah. So you've got the bile duct coming in now. You know, can you see a nice view of the stent? So see if you can see it, trace that bit down. Other way, so anti-clockwise, yeah. So you had the view coming up. Yeah, you can see the stent bit here. Anti-clockwise, further anti-clockwise. Just push the scope in slightly. Just very gentle views. Yeah. Yeah. Keep on going, yeah. So you can see the stent down there, yeah. anti-clockwise views. So I think you've gone beyond out of that area. Okay, so let's see if we can sample. Go back to D1 and we'll see if we can sample that area. We'll get a 22 gauge FNB needle, please. Yeah. Do you want to have another look at the GOJ, or are you okay, happy with that area? So while they're getting the needle, why don't you bring the scope back? Just bring it back to the GOJ while they're getting their stuff. Okay. You want to go into D2? So full little wheel twist, and then just very gentle movements, yeah? Excellent. You're right at that stent. With the tip up, you should be able to get views of that area. I just slip back. Pull back, pull back, okay. Pull back, pull back. There it is, yep. Tip up now. See if you can join it so that you can use clockwise, a bit of a clockwise torque. Clockwise torque, pull the scope back. Yeah. Getting the big vessels there. Can you see those? Yeah. That's the pancreas coming in view. Pull back slightly. Clockwise. Can you see that stent? Stent is there. Yeah. Keep on going. And you just slip from there. Yeah. Okay, so let's just take some samples from the D1 area, and then we can think from there. So that is the area we were thinking of taking a biopsy from. Can you see that? Mustafa, what do you think? Agreed in this area? I don't think we can hear you guys.
So yeah, I think this is fine right there.
Yeah.
Just a little bit to the right, a little bit right torque. I think this is good, that area, because your PD disappears in that area.
Yeah.
So that should be good, right around the stent there.
Okay.
And you can hit the stent, that should be fine.
So the needle is slightly tough in going in. It has still gone in very, it has slipped in. So just to be absolutely sure, I'll just push it out and then pull it back in so that I have not damaged the scope in any way. Okay, so can you see that slight hyperchoic area? We'll see if we can target that down there. We'll just put the Doppler, just make sure there's nothing there in between. Nothing there. Made the tip a bit sharp, and then we will see if we can. Yes, sell it. So let's see if we can take a sample in. So yeah, can we remove that? Yeah. So we're just going in the area between the PD and the CBD, where the caliber change we notice. We'll just put some suction on here. Yeah. So we should be having a sample here. Sorry. So there is a bit of a caliber change in this area with hypercogenicity, but no big mass that we were expecting. What do you think, Capia? Certainly some sludge and debris in the bile duct. We'll just see what cells turn up on it. It slipped out from that area, yeah. So that area where there's a change in the PD as well, caliber, we'll just do biopsy there. Did we get any cells? Okay. सक्शन हमने लगाया था ना शायद इस वजह से. That's the gallbladder with some stones there, you can see in the bottom. Some sludge and stones. You can see in the gallbladder, yeah. That's the portal vein coming up. That's the SNV, splenic vein. Splenic vein always moves away from you. That's the SNV, splenic vein. That's the PD coming up in view on the top as well. And just in this particular area, we are going to biopsy. Aage kuch?
It's moving away.
No, the splenic vein is going away at this level, the splenic away, because the pancreas is somewhere here like this, so the splenic vein is coming down. You can see the tip, just pulled it back slightly, just pulled it back slightly, and then I'll see if I can, just position it. So probably in the scope that excellent. So I'll just put the Doppler here. No major vessels there, made the tip a bit sharp, and then we'll come in with the So we'll just sample this area. निकालिएगा साला. Thank you.
शहजाद आप FNA करें, हम यहाँ पे नेक्स्ट केस डिस्कस करने लगे.
Okay. सक्शन लगाइएगा. हाँ, माउंट कर दीजिएगा. थैंक यू. नीडल का फ़र्क है यार. अब आजकल तो आप FNB करते हैं ज़्यादातर नीडल्स में. जो सॉलिड मैसेज हैं उनके लिए FNB है. FNA जो होता है ना, यूजली अगर बहुत कोई आप हाइलम में कर रहे हैं तो उसके लिए यूज़ कर सकते हैं, लेकिन यूजली मास के लिए FNB, क्योंकि उसका सैम्पल ज़रा बेहतर होता है और उसमें सेल्स भी आ जाते हैं. यू कैन यूज़ इट फॉर साइटोलॉजी एज वेल, बट यू कैन गेट अ कोर एज वेल. Whereas in the other one you can't get a core. Do you want to have a go again? Just have a look around. दोबारा आप विजुलाइज करें, मैं ज़रा उनकी साइड देखता हूँ, आप इनको विजुलाइज करें। I'll just see what. हाँ वसीम कुछ है?
नहीं सर, उसमें तो कुछ नहीं, तो एक खुशबू आया बस।
बहुत ही छोटा है तो हाँ।
बहुत छोटा है।
हाँ असल में ये बाइल्ड लगता है ना, तो बहुत ज़्यादा बड़ा तो आएगा भी नहीं, लेकिन ये है कि लेट्स ट्राई इट अगेन। Yeah. Okay, so that's the stent. So it's a good case in a sense. Let's see if you can follow it up to the liver. So do an anti-clockwise torque. See if you can take the bile duct all the way to the liver. Yeah. So if you, when you do an anti-clockwise, you're moving towards the liver. Yeah. Suck all the air out. Yeah. Excellent. Excellent. That's great. So the portal vein is underneath it. You're seeing the bile duct going up. Yeah. Excellent. Good views. Excellent. So that's the liver tissue is now coming in view. See if you can take it all the way to the liver. Yeah, I'll just make it slightly smaller so that you can see a broader picture. Yeah. Yeah, see if you can move it further down. So your hand sometimes has to go all the way down as well. So again, go up. If you're losing your image, go up again. Yeah, that's this further down, isn't it? Just push it down inside a bit. Yeah, now do a anti-clockwise torque. Anti-clockwise, yeah. Keep on going, keep on going. If you can see, if you can take it all the way to the liver. So push it in slightly, so that, yeah. हाँ कुछ आया sample? देखिए हाँ आगे अच्छा ठीक है तो शो आगे.
Going clockwise, pull back a tiny bit. There's your pancreas. And go clockwise and pull back a bit. Good. There we go. Keep going clockwise, and that's your pancreatic duct going towards the tail.
Mustafa, we are with you.
Okay, so you probably heard the story. A young lady with a history of weight loss and family history of tuberculosis with lymphadenopathy, massive lymphadenopathy both in the chest and the abdomen. So you'll see the lymph nodes in the periphery here and there, but we're just looking at the pancreas right now just for our usual exam. And then we can focus in on the lymph nodes. So these are obviously enlarged hypoechoic lymph nodes. That's this aorta, so that's in the celiac region. And I'm sure we'll find mediastinal lymph nodes here too. But the pancreas is not very large, and so it gets compressed easily. So here we were just fine-tuning our movements with the big wheel to identify the pancreatic duct. So we had it, but we just lost it again. So there's your aorta, there's your celiac artery coming off. So here, because of the nose, it can be hard to follow the pancreas. So sometimes what you do is, if you're having a hard time if this is your celiac artery right there, you can try and see if you can follow it into the pancreas, in which here we were able to follow it just like that. And it's a smallish pancreas, so I'm having to relax my big wheel and go over it to identify the pancreas and follow it. That's not the primary purpose of this exam, but just if you want to do it. Alternatively, in a situation it's really hard to identify, you can just go past the G junction, go a couple of centimeters, suction and go clockwise, and oftentimes you'll just land on the pancreas. So you have two different approaches. You can follow the artery from the celiac, just keep following it, seeing if it takes you into the pancreas like that. Or you can do the blind approach, which is go past G junction, go a couple of centimeters in, and go clockwise and spin around, and you will typically find pancreas that way too, which is, I went too far, so I was spinning and I was pulling back. So there's your pancreas. You could try both. So for that you have, there you go, and you're on the pancreas right now, right? So past G junction a couple of centimeters, go clockwise, and now the lymph nodes I think are making it harder to see the pancreas, but this above is pancreas. These are lymph nodes, and yeah, there's all these lymph nodes. So you can go counterclockwise towards the neck because you see more pancreas that way, big wheel slightly towards you, and keep big wheel towards you and go. There's your confluence. So the pancreatic duct is going to go down this way. So go counter and big wheel towards you. And find the confluence again. Good. And now push forward a bit. Because you want to see the, and now big wheel towards you, and you'll see if you can see the duct go clockwise. Once you have the SMV in view, you go generally slightly clockwise. But again, it's hard to make out pancreas beyond on the other side because of the lymph nodes that are all over the place. But that's it, big wheel towards you. There's your pancreatic duct, right? Or unless it's a vessel, let's just double check. So that's still a vessel actually. So go counter. Just spin around here, just see if we can identify the pancreatic duct. Go counterclockwise. Pull back a tiny bit. There's maybe, it's hard to tell with certainty. Pull back a tiny bit. Ye wala. This might be it. But it's essentially a small normal duct right there. We see part of it. And then keep coming down and go clockwise, sorry. We may not necessarily see. So this may be enough for the stomach view in terms of pancreas. Obviously we've seen a bunch of lymph nodes. If you pull back big wheel towards you, good, and then pull back and it'll go big wheel towards you. And we're going to look for the liver here. So show us the liver. Good. Now you're going to go clockwise on the liver to see the portal vein in the middle, and that will usually take you to the porta hepatis. So there are some portal veins with the bright walls. That's good. Big wheel towards you and go clockwise. Keep going clockwise. There you go. So pull back a tiny bit more and go clockwise. There's your portal vein. Keep going clockwise. Keep going clockwise. And now you have your portahepatic lymph nodes coming into view. So keep pulling back. Show us this view. So good. And go clockwise. Yeah. And these are your portahepatic lymph nodes. So that's your portal vein. There are the lymph nodes. Keep pulling back more. Keep pulling back. Good. And go clockwise. Keep going clockwise. And go the other way now. So right here, now pull back and show us these nodes. These are your portahepatic lymph nodes. If you go clockwise to the celiac, towards the celiac, so keep going clockwise here. Keep going clockwise, keep going clockwise, keep going clockwise. And there's your, now you're seeing the celiac lymphadenopathy. Look at this, I mean, they're massive, right? This, here, these. Okay? Good. Now you can go to the bulb. हाँ जी जी Okay, good. Ultrasound. So now you're in the bulb. So just almost big wheel towards you. There we go. Okay. There's your, okay. As soon as you get in, there's your portal vein confluence going on. So as portal vein, if you go counter here, you'll go towards the liver. So relax your big wheel and go counter. There's your pancreatic duct, or it's still a vessel. It's tricky in here because I keep thinking and then it turns out to be a vessel. So cursor off. That is pancreatic duct right there. So keep going counter, relax your big wheel and go counter. You're going clockwise or counter? Looks like paradoxic movement. The push forward. Don't section too much. Just push forward your probe. Make contact with the scope, with the wall. Relax your big wheel. Keep advancing. Keep advancing. And relax your big wheel. Relax, 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 relax. And keep pushing forward. That's it. Keep pushing forward and go counter. There you go. Now relax your big wheel. Your bile duct's getting compressed. So right here, the bile duct is getting compressed. So relax your big wheel and keep going counter. Keep going counter. Keep going, keep going, keep going. Okay, we lost the view a bit. Go clockwise. We have a bit of a paradoxic view because this is your portal vein and you should see the bile duct here somewhere. I'm going to take over just for a second. There. That's artery. I think so. Yeah. So here, there's gallbladder. I think what we're going to do is go drop down to the left here. And so now this is part of gallbladder to the left here, to the apex here. There's your gallbladder. And if you have your, I'm going to take this off for a second. This here now is your bile duct. This one. So sometimes when you're having that issue, the way I usually approach it is, I will, just to show you, if you go in like this and you can't see it, I will drop my left hand, extend my big wheel, and find my portal vein like this. When I have my portal vein here, that's the, just for purposes of identification, once I have my portal vein here, and you see the artery is this structure here, usually you just have to spin around to see, okay, where can I see my duct? And here, there's gallbladder, so if you see gallbladder, you're close to the bile duct, and you just go clockwise, and this structure here is your bile duct. And you can confirm with flow. So vein, artery above, and then there's your bile duct. And then once you have the bile duct in view, you can go clockwise towards the towards the pancreas. So there's the bile duct. We're just following it. It's a moving target in this one, so it's hard to stabilize. But this is the bile duct coming down into the duodenal, into the papilla, and then you can go backwards. There's the pancreatic duct. Not a nice round view of the bile duct, and here it gets compressed. That's why it's hard to sort of follow. Okay, but the maneuver here is, if you get in, you can't find it, drop your left hand usually, relax your big wheel, and land on the portal vein this way. And once you have it like this, a round circle, usually you'll be able to find the bile duct, but your hand is looking downwards. So I want you to try that. Good. Now, so push forward a bit more. It's okay. You have to see something recognizable, liver or lymph node. There you go. So you see, now you see liver. So relax your big wheel. No, just relax the big wheel. Good. Relax. Push the scope forward and drop your left hand. Relax your big wheel as you drop. Relax and push forward. There you go. There you go. Keep going. Now you're going to land on the portal vein in a second. So keep going. Keep going. Good. Keep going. It's okay. And now slightly big wheel towards you and go clockwise. But don't lose this view. You have to go in even more. See, relax your big wheel. Relax the big wheel. You see this? Now you want to go there. There's your portal vein, right? Right up here. So now you found the portal vein. Now big wheel towards you and go clockwise. Big wheel towards you because you don't want to lose it. So pull back. Big wheel towards you. Big wheel towards you. Big wheel more towards you. Bring the portal vein to 6 o'clock. Well, there you have your biodeck, by the way. This maneuver takes a bit of practice, but that was the idea. That's your portal vein, so relax. Relax your big wheel. Follow this portal vein. That's it. Relax your big wheel. Relax your big wheel. Okay, now keep going counter. Keep going counter. Relax your big wheel at the same time. Keep going counter, relax your big wheel. I want that as a round structure. So it's up here, so you have to push forward more. Relax your big wheel. Relax your big wheel. Keep relaxing. Keep relaxing. That's it. Keep going counter. Your hand should almost be pointing downwards. There you go. You hold on. Relax. Relax your big wheel. Relax, relax, relax. Relax it. Like this. This is relaxing it. You're not relaxing it. Okay, you have it too tight. So this is relaxing it. This is too tight. So when you relax it, now do gentle big wheel towards you. Gently. You don't want to compress. Big wheel towards you. Big wheel towards you. You're losing your portal vein. There you go. Okay. Now in this area, usually you will have your structures of the ducts. So थोड़ा सा इसको गोल करना है. So you have to figure out how can I make this round. So you go relax your big wheel, go counterclockwise. There you go, and then relax your big wheel. Oh, you lost it. That's okay. Push forward. There. Okay. There's your okay. That's your vessel. Now this is good. Go clockwise. Maintain the round structure. Big wheel towards you a tiny bit. Big wheel towards you, go clockwise. Big wheel towards you, I want you to bring this to 6 o'clock. Okay, good. There's your bile duct. You see that? So once you have the portal in a roundish fashion, you can identify the two ducts. So that's going towards the papilla, now go counter. Maintain that position. Go counter from here. Keep going counter. Keep going counter. Keep going. There's your bile duct. So big wheel towards you. Big wheel towards you. Big wheel towards you. It's going up there now. But that's essentially it. Okay, let's go to second portion. Big wheel towards you. Right? It's like a Durian square. Okay. Small wheel to the right. Small wheel to the right, don't push. Just small wheel to the right, there you go. Okay, good. And no need to lock it, just pull back and reduce. Good. Very good. Okay, we're going to simplify this. There's no locking, relax. No complicated second portion. Can you bada kar dein zara? All you do, just like in EGD, you get in, you go smaller to the right, big wheel towards you, and then you gently reduce. If it's a very tight turn, which you may have, you have to be careful, and you slow down and see if you can get it to go down just from rotation. If you can't tell where it is, you have to really slow yourself down. So now, because I couldn't tell, now I'm just doing my wheels, smaller to the right, big wheel towards me, and I'm going to push in a bit because it's unstable. Unfortunately for you, this is not an easy second portion for the EUS stroke. But gently reducing and looking to see if I can see my papilla. I don't know if I'm above it or below it, so I'm going to keep looking on the way back slowly. And I think I'm still too proximal. So here I'm going to try and... The other thing is you have to remember what is the purpose of this exam. If the purpose is not to evaluate the papilla and it's mainly for tuberculosis purposes, then obviously you can stop doing the same thing if you keep falling back. This time now, because I couldn't reduce, I'm going deeper, but a lot of big wheel towards me, so I don't like perforate with the tip of the scope. And now I'm going to gently do the same maneuver from a deeper position to see if I can get into position, but I would have a low threshold to just stop and get on. You see, because now we're starting to cause trauma. So you have to be careful, but here we went deeper, and now that I'm reducing, I seem to be in a reduced position in a more stable situation. So I'm going to see if I can identify the papilla, and if I do, or if I think I know where it is, then I'll stop. But here's my papilla. I saw it briefly endoscopically right here, right there. And so I know that it's somewhere here, so I'm going to stop, push my scope here, small wheel to the right and big wheel towards me, and I'm going to start, I'm going to start my evaluation. So lymph nodes right away, mesenteric vessels, more lymphadenopathy all over, right? And I can just tell you from the feel thing that this is a very unstable position. So I'll see if I can see my ducts, but if I don't, it doesn't. And we just get on with the biopsies of the lymph nodes.
So, Mustafa,
Yes.
actual practice, if you're sent a patient is sent to you for lymph node FNB, and you see them pretty much straight away, do you complete the examination despite of a good CT scan, or would you just go and do an FNB and
Yeah, I think it depends. When I'm training fellows, I will ask them to do it, but keep that in mind that if you can't do something easily or quickly, for the sake of the patient's safety, let's not mess around. You know, you never know. Within 5 minutes, there's a cardiac issue or a pulmonary issue, and then you have to abort. So,
Okay.
if the patient's easily doable, I would still let them do it for training purposes. Otherwise, in this type of situation, you can go and get targeted biopsies and get out.
Okay.
Also, if you're a high-risk patient, considering, you know, transmissible diseases, that's another area.
I think one other point is that depends on also whether you're doing it under sedation or whether your patient is under.
Absolutely.
So if your patient under sedation, then you just want to finish the job and come out rather than making them very uncomfortable
Yeah.
trying to do something that. The other question here is what kind of needle what size needle do you prefer depending on which location you're biopsying? So let's say starting with uncinate, do you have any preferences? And then normally I assume you use 22G, but please share what you would do.
Yeah, so normally for any lesion, lymphadenopathy wise, if it's more than a centimeter or even less, to be honest, generally the go-to for me at least is a 22 gauge biopsy needle. Sometimes for small nodes that are suspicious, recurrence after a Whipple or something and subtle, then I would needle it. Then I would go with a 25 gauge, but my standard starting point usually would be a 22 gauge.
And that would be for uncinate as well?
Yes, uncinate too. Sometimes if I start with the 22 and I'm not getting if by looking at it, if it's really deep and I'm worried about the angle, I may consider less needle like a 25 because it's smaller, so it's less stiff. But usually you can get the 22 to come out as well.
Okay, do you ever use a 19G needle?
I don't. Not for sampling. Oh, only liver biopsies. But otherwise for lymph nodes, I don't use 19s at all.
Okay. And sorry, for lymph nodes, your method of doing FNB is just standard without any suction or
Yeah,
what is, can you just share with us what
yeah, I'll
you do?
just show you, but I usually, my standard approach is slow stylet pull. Fine, I'll just go through it like in this case. I'll identify what seems to be a relatively straightforward target, find my needle tip. You can use your elevator to sort of identify where the tip is. And then with this needle, when your stylet is in all the way, the sharp tip of your needle is actually blunted by the stylet. So you have to pull back just like a centimeter or less, even half a centimeter, for the sharp part of your needle to be exposed. And then I will just do my puncture
Hasnan,
and I will push it in and have my assistant do a slow pull. And then we're just going to do, like Dr. Hassan was saying earlier, you just do you do deliberate movements, not sort of random movements. And up to like 8 to 10 to get nice cores of tissue. That's my usual approach. And you go to the depth of the node, you try not to cross it. It's not the end of the world if we cross the node, but you prefer not to, especially with large lesions. You can avoid that. Sometimes for small nodes, you may end up crossing the node. So now that we've done about, 10 plus, I'll just pull out my needle and pass it to my assistant. Also, with large lesions, you can basically, your slope can slip off of them. So keeping them slightly to the right, big wheel towards you, and pulling back to try and sort of hug the lesion, and then you can basically put your needle down and sample it. I will also oftentimes lock my wheel in these situations and may have my assistant hold the scope. Any comments, or you're interested to know about how you do it, Dr. Sadmian?
Depends. If I've got a new needle, then I would do what you've done, but we don't do a slow pull. We just go ahead and pull the stylet out, and then just continue taking 6 to 8. It's also the feel. I felt, if it's very soft tissue and you don't feel the slight, gritty feeling that you get when you're actually going through the tissue and you feel it's getting in. If that isn't there and it's very smooth, then if I don't get a sample, then the second time I use a suction.
Sure.
And dry suction is what we use here. In patients where unfortunately we end up reusing needle, I would again do the same, but my threshold for going to dry suction is much lower.
Sure. It's interesting, in our group of 7, I don't know if there's anybody else who does slow pull. I may be the only one in the group who does it. So it goes to show you can get it either way, but yes, sometimes when your yield is compromised, then it may help. Interestingly, you will often see these needle tracts both in large lymph nodes as well as in liver biopsies, something to be aware of. And if the node suddenly becomes much brighter, that may be because there's been bleeding from your sampling. I didn't necessarily Doppler this before I did it, but it's good to make sure to look for vascularity inside the node as well.
Mustafa, when you see that, then the suction thing becomes a problem because you're only going to be getting blood.
Yeah,
that
exactly.
is the problem. So it's best, if you have other lymph nodes, then it's better, I guess, to go
to a different target. Exactly. So here we're not necessarily seeing bleeding and it's not hyperechoic. So this still remains one of the easier targets, and my scope is nicely positioned. So I'm just going to go after this again. And I don't know what your practice is for TB. We talked earlier, 1 in saline. Do you always, what's your number of passes you do in these situations? Assuming you have good tissue.
What's the number of, sorry, I missed
Number of passes that you would do. If you get you're getting good tissue.
In this particular case, because you need to probably send it for saline for PCR and, so probably, twice in this case. If you get good samples the first time, you got nice white core, then I think that's good enough. That's what we do.
Okay, because we don't see TB, so I'll do whatever you guide me to do here.
So you really need to bring one out for saline, which goes for PCR and gene expert, and then you do the regular routine. So you need 2 samples here.
Okay. So we'll see dikhate hain how's the tissue, and we can decide whether, and
What was the Mustafa? The feel was like a very softish thing, or
it's like, you know, not hard. It's like it's going easily, and it's not bouncing away. So it didn't feel like total mush fluid. It's like a middle of the ground type of a feel. And for just curiosity, you will reprocess this needle as well, like tuberculosis needles get the same treatment as cancer needles. कैसे अच्छा तो और कर लेते हैं लेकिन साइड टिश्यू ही है हाँ ठीक और ये भी निकल रहा है So we got not a lot of tissue, but some tissue. So I'm going to do more passes. The only question in my mind is, if it's very enlarged, if there's necrosis, should I be targeting a different node, which is maybe smaller in size?
sorry, Mustafa, was the sample?
It's mediocre.
Okay.
There's tissue, but there's not a ton of tissue.
So would you do the same thing in your practice, or would you change?
No, what I'm thinking is, because the very large ones may also have more necrosis, maybe go with a smaller node. That's what I would do normally in my practice. But again, tell me, because we don't deal with TB, what your approach would be here.
No, I mean, you can go for whatever is easier, but I think you will have this problem probably in most of the lymph nodes.
Okay, so just do more passes.
So
Yes.
I would now, if I don't get sample here, then as I said earlier, I would go with suction.
Oh, okay, so change to yeah, we can do that to section there then. अच्छा thank you. Or
Section में the method that I was taught by Khalid basically was that we go in with without suction. The first pass or 2 are without suction. Then I switch on the suction. We do 5-6 passes with suction on, and then close the suction, do another couple, and then come out. So why I do it is purely because Khalid said
Sure.
this is how he does it, so I just followed it.
well, he knows what he's talking about. So I think that's a reasonable approach.
So I do, I call it an intermittent suction,
Sorry,
and
sorry.
that works really well with the easy shot, Mustafa.
Okay.
And so that's where I started using it. So the concept behind that is I don't like using suction. That's one thing. It sucks the blood. So what I do is like do a couple of passes, like to and fro movement, maybe 3-4 without suction. And then I turn the suction on, do 3-4 more like that, and then turn it off, and then do without suction again. The reason for that last 3-4 back and forth without suction is because I don't want the blood at the tip of the needle. Okay? So last few, I want to do it without suction, so the tissue comes in with the first thing which is going to be expressed on the needle is which is at the tip. So I want that tissue. So that's, and I think with that also, I decrease the amount of blood which is being suctioned in that tissue. So that's the
Yes. So now we're going to turn the suction on. I did a couple. I'll do a few with suction, and then I can turn it off and do a couple more. And then they can show you the slide as well.
So Mustafa, I note that with FNB, the movement is slow both inwards and outwards.
Yes.
Whereas in FNA, you have quick kind of jerky movements.
Yeah.
Because you end up doing, if you're fanning and you're fanning at 4 different sides, then you'll end up doing 4 in each at least. So you're doing it almost 16 times. Whereas in
Yeah.
FNB, you don't have to do that. So you just have to be slow in and slow out.
Yeah. So we did.
So in the first sample, we've got the pictures of the cells. So what we can see is lymphocytes there. Right.
So we're in the lesion, huh?
yeah, well, not only we are in the lesion is in the needle too, so that's good.
Good. Yeah, both are important.
And both are important. So you could be in the lesion, but if the lesion is not in the needle, that doesn't matter. Yeah.
You can see that any node that you sample does get a bit bright with some bleeding inside, which is not uncommon. But again, if you're having to do multiple passes and you have multiple nodes, you might want to keep changing your target so you don't get bloody specimens. कुछ नहीं थोड़ा सा ये नया कि पुराना है
ये तो पिछले वाले दिन
we're just getting in not a lot but कितना चाहिए होता है the question is how much do we need okay. So we're just getting like small little pieces. I'll probably end up repeating this a few times.
Yeah, or Mustafa, I think because these are the inflammatory lymph nodes, fibrosis develops in those as well. It's one thing is necrosis, on top of that healing process, fibrosis.
Yeah.
So it's usually sometimes hard to get a lot of tissue on that.
Yeah.
So I think maybe just use a suction on that because you got a good cells on slide.
Yeah.
So that means at least you're getting specimen and just maybe even more, do more back and forth movements.
Sure. So we're going without the stylet and we'll do just suction. I got it. Yeah, आप कर लें, do the mediastinum evaluation. So go ahead and IVC, and then from here just pull back to see the chambers of the heart. Okay, Smith, it'll be good to see the lymph nodes. So keep pulling back.
Mustafa, we're gonna present the next case. You guys can continue.
Thank you.
Thank you.
So keep pulling back. Keep pulling back and spin around. There's your heart. So when you see the heart, keep it in view. And keep spinning, and there's your spin. Good enough? Okay, good. So go the other way. Keep going counter. Keep going counter. So there you go. Left.
So we need to establish the fat plane between the node as well as the pelvis. ये तीन चीजें करनी. So you comfortable with station 1
Can
at
we-
the GOJ? है ना? चलिए, that's fine. Let's just start. और आप अस्सलाम वालेकुम कैसे हो आप? अस्सलाम वालेकुम कैसे हो?
Farooq.
जी जी जी
Can you hear us? We are with you now.
जी जी मैं I can hear you. Can you hear me?
Yeah, we can hear you, but we can. Oh, now we see you. Good.
हाँ fine fine. एक मास्क दे दियो please. So I'll just, have you guys discussed the case already and seen the CT images?
We didn't see the CT image, but we did talk about the patient.
जी, ठीक है. So the contract between the trainee and the trainer is we need to establish three things. Number one, we will look for the head of the pancreas. Number two, she's got a dilated bile duct on the CT, but LFTs are normal. So we will also try and trace the CBD into the mass. And third trainer contract is whether the mass is unrelated to the pancreas, like a nodal mass. So is there a fat plane between the pancreas and the nodal mass? Or is it an exophytic lesion coming from the pancreas? So we'd like to answer these three things. Or uske baad, Junaid has done good 25 number of cases, so I think it's very reasonable. He should at least have an attempt at FNB as well. Mask. Ekeda mask है ना? अच्छा. Normal भी दे दीजिए. हाँ normal दे. Thank you. इसको ऐसी जगह रख देते हैं जहाँ से ये बेचारी गिरे ना. नहीं ऐसे नहीं करते. मेरा ख्याल है मुझे कॉफ़ी यहाँ लानी नहीं चाहिए है ना. Let me just talk him through. 7.5 gloves, please. So this is Olympus system. Yeah, very nice. Refugee system. Okay, that's fine. So that's right. Very nice. So aorta in the sliding position. Yes, thank you. Very nice. So keep it into that position. Keep aorta in the vision. Very nice. Very nice. अच्छा जब आपको लगे ना कि ये aorta इधर जा रहा है, तो all you do is big wheel को थोड़ा सा अपनी तरफ कर लो. Big wheel अपनी तरफ करोगे ना, तो you'll see it coming, and then you can just push very slowly, keeping aorta in the middle. Very nice, beautiful. Yeah. Celiac and yes. Can people see that? It's a very clear take off the celiac as well as the SMA. Very nice. चलिए. जी. अच्छा ठीक हो गया. हाँ जी बिल्कुल ठीक है. Very nice. So try and keep that takeoff in the vision. Yes.
follow the celiac.
Very nice. Very nice.
Letting go my big V and
Yeah, yeah.
skate into the
Very nice. So we've gone a lot more to the anti-clockwise there. So this was the yeah, you need to go further. Keep going. Oh, so patient is.
waiting for the situation to get
Lovely. Keep going. Very nice. There it is. Very nice. Very nice. So there are some celiac nodes as well, aren't there? You know? You just shown me a celiac node. Yeah, there it comes. As you go slightly more, there it comes. Very nice.
So to follow
There.
the celiac, I have to go anti-clockwise, right?
Yep, that's right.
And push the scope as well.
Push the scope about 2 centimeter in, and if it's not, you just take your big wheel away, you will land on the pancreatic body. Yeah, so that's your SM vessel. These are your splenic vessel, and that's where you look. So if you just,
I'm just waiting for them to settle down a bit. Yeah.
okay.
Falling back at the liver.
You are beautiful. This is such a lovely image. 100 pounds worth for training. Very nice.
Get a glimpse of the
Yeah.
vessel. Yeah.
So you push couple of that's okay. And this is a pancreatic body.
Yeah.
So to reach here, screen is the middle. You push your scope forward 2 centimeter forward and take your big wheel, keeping that in the vision. Yeah, so that's the pancreas. That's for sure is the pancreas. Okay, we're back at the liver, so we've gone, yeah.
ये जो एनेस्थेटिक्स टेक्नीशियन है ना थोड़ा सा लेफ्ट पे हो जाओ बेटा बिकॉज यू आर कवरिंग द होल थिंग थैंक यू
So what I'm trying to do is to follow this vessel.
The celiac, as yeah, that's okay, which is fine. But then I think because of the mass, the anatomy is slightly bit altered. There you are. You're on the
Yeah.
yeah, yeah,
These are the vessels.
yeah, yeah. That's fine.
Let go my big V. I can see the atrophic pancreatic parenchyma.
It is,
I'm unable
it
to
is.
keep my sphenomesenteric vessels.
That's right. That's right. And that does look like a PD, doesn't it? Okay, so you just go slightly anti-clockwise, and that is a PD. So the vessel that comes through, maybe I'll show you. Where's the arrow here? This one. Yeah. So this
That's the
is actually,
pancreatic.
yeah, that's a PD. This is not a vessel, this is a PD. Yeah. And arrow has run away. So this is PD, this is the body of the pancreas, and if you just take it slightly anti-clockwise, very slight, you should see from the body it runs down into the head.
Yep, I can
So
appreciate that, yeah.
Yeah, lovely. So dilated PD is always not a sign of happiness, right? So this probably is not just a retroperitoneal, it probably is the pancreatic mass. And as you rightly said, there's a distal pancreatic atrophy, isn't it?
So there is like,
Yeah,
that's the pancreatic duct, yeah.
Yeah. Just show me slightly more, a bit more to the anti-clockwise. Very slight with the view of the PD. Yeah, there you are. Oh, sorry. Yeah, so it's about, in the genu it's about 5. So we know that it's dilated. And you can see it becoming ectatic and coming towards the head, yeah? And if you just, I think this may well be the bile duct actually. So big wheel down, very slowly big wheel down, that's a bile duct actually. That's a portal vein, that's a bile duct. Yeah. So this is your PD coming there, and probably this next to it is so ye PD hai. So this is the differentiation where the portal vein goes in the middle, the top is the body and the neck of the pancreas, this bottom is the head. So ye aap head mein dekh rahe ho PD, and the right next to it is the bile duct. Okay, but we